Good evening, ladies and gentlemen. On behalf of my colleagues in the organizing committee of Dubai Pediatric Club, I would like to welcome all viewers from Dubai, other cities in the UAE, GCC countries, and all countries across the globe. Today we have a webinar called Pediatric Gastroenterology and Hepatology. This webinar is conducted in collaboration with NMC Specialty Hospital Dubai, and it is CME accredited. This webinar is sponsored by Vita Biotics UAE. I would like to thank the country business manager of this company, Mr. Tawfiq Ali. Well, we have today eminent speakers and panelists. We have Professor Dhawan from King's College Hospital, London, Professor Ujjal Podar from Lucknow, India, and Dr. Miqdadi, Senior Consultant, Pediatric Gastroenterology from Abu Dhabi, UAE. In a short while, I'll be introducing them. Well, as usual, we have a question. All viewers are requested to write their answer in the Q&A box. Who is this gentleman? And what is his contribution to the field of pediatrics and especially pediatric gastroenterology? You have about 2-3 minutes time. Beautiful Dubai, welcome to Dubai, one of the most beautiful cities in the world. Best time to come and visit this beautiful city. The members of Dubai Pediatric Club, on behalf of all of them and on behalf of the organizing committee, once again, I would like to welcome all viewers to this webinar. Well, in the organizing committee, myself, Dr. Joshi, past president, Dr. Kalpana Sengupta, secretary of the club. She is our moderator today. Dr. Diari Muhammad, chairman of academic affairs. He is also with us. Dr. Amir Muhammad Toleimat, Dr. Ayman Jundi, Dr. Rafia Awara. She is a senior specialist pediatrician at Prime Medical Center, Jumeirah, manager of that one. She is also moderator today, Dr. Srinivas Bandari, honorary member, Dr. Leila Bahi, and Dr. Khalid Rashid. Well, today we have eminent speakers and panelists, as I mentioned, Dr. Anil Dhawan, Professor and Consultant in Pediatric Hepatology, Director, Research and Innovation, King's College Hospital, London, Director, Pediatric Liver and GI Nutrition Center at Mowat Labs, King's College Hospital, London, UK. We have with us Dr. Ujjal Podar, Professor and Head of Department of Pediatric Gastroenterology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, India, and Dr. Muhammad Miqdadi, Division Chief, Pediatric Gastroenterology and Hepatology and Nutrition Division at Sheikh Khalifa Medical City, Abu Dhabi. He is also Adjunct Associate Professor, Department of Pediatrics, College of Medicine and Health Sciences, UAE University. Well, I would like to announce here that our 8th annual Dubai Pediatric Conference will be held on 26th and 27th November. It will be at Queen Elizabeth II Hotel Dubai. Is the only floating hotel in the UAE and Dubai. Well, beautiful view of the conference hall of the Queen Elizabeth Hotel. We will have a gala dinner and program at this hotel. And you see here, the members of the Dubai Pediatric Club at different gala programs, starting from first and going here. You see Dr. Khilnani Joshi and here Dr. Bhatt. So we are waiting for all of you. Well, I would like to thank our sponsor, Mr. Tawfiq Ali, the country business manager of the Vita Biotics, who is always helping and supporting us. Well, I'll give a very brief account of history of pediatric gastroenterology and pathology in just 2-3 minutes. Well, Adolf Kussmaul in 1860 8 developed the gastroscope. Rudolf Schindler in 1932 developed a semi-flexible gastroscope. He is also considered the father of gastroscopy. And Dr. Hitchkovich in 1957 introduced the first fiber-optic fibroscope, just to remember them. And Dr. Margot Scheiner, she has been credited with initiating the emergence of pediatric gastroenterology as a distinct clinical specialty. She also invented in 1956 the biopsy tube. Well, regarding pediatric hepatology in Europe began in Paris at Bicêtre. In French, it is called Bicêtre, in English, Bicêtre Hospital in 1964 by Professor Allergy. There is one syndrome, allergy syndrome in Britain. The first center for pediatric hepatology was developed at King's College Hospital in London in 1970 by Dr. Alex Movat. Our speaker, Professor Davan, is at this center, director of this center. Well, here you're seeing Dr. Movat with Queen. The publication of Dr. Movat's first book, Liver Disorders in Childhood, in 1979, indicated that pediatric hepatology had now become distinct from adult hepatology. Well, Alex Movat is the person who was in the question, the first chair of pediatric hepatology in the United Kingdom, followed by Dr. Vergani and subsequently Dr. Kelly, just to remember them also. Here you see Dr. Davan with and Andre Movat. But once again, I would like to introduce our speakers and panelists, Professor Anis Davan, Professor and Consultant in Pediatric Hepatology, Director, Research and Innovation, King's College Hospital, London, Director, Pediatric Liver, GI and Nutrition Center, and Movat Labs, King's College Hospital, UK, London, UK. Professor Ujjal Podak, Professor and Head of Department of Pediatric Gastroenterology at Sanjay Gandhi Postgraduate Institute of Medical Education and Sciences, Lucknow, India. Their detailed profile has been circulated. For the sake of time, I'm mentioning briefly. And Dr. Muhammad Miqdadi, well known in Dubai, UAE, and the region, Division Chief Pediatric Gastroenterology and Nutrition Division at Sheikh Khalifa Medical City, Abu Dhabi, and he's adjunct associate professor of pediatrics at College of Medicine and Health Sciences, UAE University. He's also program director, Pediatric Gastroenterology Fellowship Training Program at SKMC, UAE. Well, with that I end. As Hippocrates said, all disease begins in the guts. Beautiful Dubai. Thank you very much. Now I would like to request Professor Ujjal to start his talk. I would like to request all viewers to write their question and answer in Q&A box. After completion of the talks, we will start the panel. Over to you, Professor Ujjal, please.
Thank you, Saurabh. Let me yeah. Okay.
Not yet.
Am I audible? My slides are visible?
Yeah, your slides are not visible, doctor.
Not visible?
Yeah.
I'm showing it from here.
Yeah. You can close that, doctor, and restart again, because I think you use this tab. You can use like share your full screen.
No, now it has come?
No, doctor. It will not come. No, just close this and stop sharing once.
Stop sharing. Yes.
Yeah.
Now again, I start share.
Start sharing and use like, don't use the tab. You use like the full screen.
Now,
Yes.
has it come?
Yes, doctor.
Yes, yes.
Is it visible now?
Yes, doctor. Please go ahead.
Okay. Thank you, Saurabh. Saurabh and I were together during our MD days in PGI Chandigarh, and I must thank the Dubai Pediatric Club for giving me this opportunity. The topic we decided to discuss is about the inflammatory bowel disease and intestinal tuberculosis. Confusion to the solution. Now, why this question of confusion comes? Because the tuberculosis, especially intestinal tuberculosis and Crohn's disease, they mimic each other. If you see that tuberculosis is an endemic in developing countries, I guess besides India, in UAE also it is pretty common. And we have the data in 2021 that incidence of tuberculosis in India is 188 per 100,000 population. A quarter of them are extrapulmonary and a significant proportion of extrapulmonary are GI tuberculosis. On the contrary, IBD, especially Crohn's disease, is less common, definitely less common than tuberculosis. However, all over the world, especially in this part of the world, the incidence of IBD is increasing. Now, if you see the clinical, endoscopic, radiological, and histopathology, these are the four things we use to diagnose Crohn's disease and tuberculosis. All four of them, you will see there are a lot of similarities between these two diseases. So, in the real life, often it is difficult to differentiate this is tuberculosis or this is Crohn's disease. Now, what is the connotation? If you miss the diagnosis of tuberculosis and put the child on steroids as thinking of Crohn's, then there's a risk of dissemination of the infection. On the contrary, if you miss the diagnosis of Crohn's disease and put the child on anti-tubercular therapy, you will delay the diagnosis of Crohn's, and that may lead to the progression of the Crohn's disease. Patient may develop complication. So in real life, this is the real dilemma we face when you handle a child with intestinal tuberculosis versus Crohn. So what I will do, I will take you through the two cases, the real life journey of two cases to differentiate between tuberculosis, intestinal tuberculosis, and Crohn's. The first child is a 7-year-old girl who presented to us with a history of streaks of blood in the stool for 2 years. She was having mild intermittent pain abdomen of the same duration and some kind of anorexia and malaise. So what the detailed history mother said, 1 to 2 stools she was passing. It is a normal form stool, normal volume, not diarrhea at all. Occasionally mucus, but what she was passing a fresh blood which is sticking the stool is basically because of the most probably the anal deletion. There is no history of urgency, no history of tenesmus, no nocturnal diarrhea at all. She didn't have any history of fever. In the family history, one of her paternal uncle had tuberculosis, but that to lymph node tuberculosis 5 years back. There is no history of pain abdomen, vomiting, or abdominal distension to suggest subacute intestinal obstruction to this child. And she didn't have any extraintestinal manifestation in terms of oral ulcer, joint symptoms, skin lesion, or red eyes. Now, when we examine this child, her anthropometry is bang normal. Her weight was 22 kilo at the age of 7 years, height 119 centimeter, both are more than 50th centile. She didn't have any pallor, edema, or any vitamin deficiency signs, no significant peripheral lymphadenopathy either. Abdominal showed just 1 centimeter liver, no lump, no tenderness. However, her perianal examination showed a tag and fissure. Other systems are normal. So what diagnosis we have thought? This is a child who was having some kind of anorexia, malaise, little bit of rectal bleeding and pain going on for 2 years. So we thought it may be Crohn's disease, it could be tuberculosis, other two lymphoma and immune deficiency. Less likely, the 7 years, no previous history to suggest any multi-system involvement. So infection less likely and duration is taking you away, most probably from lymphoma also. So we started investigating. If you see the investigation panel, as hemogram means CBC showed normal hemoglobin platelet normal. However, her inflammatory markers are marginally elevated. CRP was 2.2 and ESR was 40, not dramatically high, but it is elevated. Her blood biochemistry showed normal serum protein albumin. Her tuberculosis workup into Mantoux test, chest X-ray, even the gene expert in the biopsy are negative. Immune deficiency workup in terms of both congenital and acquired immune deficiency, immunoglobulins and HIV are negative. So what next? Obviously, when we are thinking about intestinal tuberculosis versus Crohn's disease, we need to do the endoscopy. So we call it top and tail, both upper GI, lower GI, and you need to evaluate the small bowel as well. So you need CT or MR interrogation. So this is the colonoscopic picture of this patient. Rectum absolutely pristine, normal. There is no lesion in the rectum. Both ascending colon, transverse colon, descending colon, normal. However, there are lesions localized to the ileocecal region. There are ulcer over the ileocecal valve. You can see the deep ulcer, gaping ileocecal valve. There is a linear ulcer into the terminal part of the ileum. We got the CT enterography done, which was pristine, normal. There is no evidence of any lymphadenopathy, no circumferential mural thickening of the intestine. Upper GI endoscopy was normal as well. And we got the histopathology of colonic biopsy. We showed the laminopropria showing mixed inflammation with occasional granulomas. However, this biopsy was negative for Jill Nelson stain for tuberculosis, and gene expert was negative. Histopathology from upper GI endoscopy, normal duodenal creep-glass ratio, and the pathologists couldn't find out any focally enhanced gastritis, which is one of the features of IBD, especially Crohn's. So where you are, what is the diagnosis? We have is it tuberculosis or Crohn's? This is a middle-class family child who came with a history, doubtful history of contact. He has totally 2 years history of just milder kind of pain, abdomen, anorexia, and colonoscopy showed the localized involvement of ileocecal region, mainly the ileocecal valve and terminal ileum. We got the colonic biopsy, all segment normal. There is no creep distortion or any architectural changes to suggest chronicity. And we got a CT abdomen showing normal small bowel. So where we are? Is it tuberculosis or is it Crohn's? Now, there is no telltale evidence to suggest it is Crohn's, no telltale evidence to suggest it is tuberculosis either. We didn't get any microbiological confirmation of tuberculosis. Since this is in the endemic country, we thought let's give a trial of anti-tubercular drug. This child was started on 4 drugs, anti-tubercular therapy, followed by 3 drugs. We have treated her anal fissure with nitroglyceric ointment and stool softener. Now what happened to this child? 6 months after anti-tubercular therapy, mother said there is some improvement. Streaks of blood had reduced from daily to once per week. She gained 1 kilo weight and 3 centimeter height. Her hemoglobin improved from 10.5 to 12.5. Platelet count remained normal, which was normal, and ESR CRP marginally still elevated. Repeat colonoscopy done, almost same picture. There is no worsening, but there is no mucosal healing either. So what is the option left? So we have given the option of starting treatment for Crohn's, or we can extend the anti-tubercular therapy because there is some marginal improvement in symptoms and blood parameters. So parents agreed for extension of therapy. At the end of 12 months, there is a worsening of this child was showing improvement in first 6 months, then there is a worsening. She developed significant anorexia. She gained 1 kilo first 6 months. This time she lost weight. Her pain abdomen became more frequent. Blood became more often. The hemoglobin dropped further to 10.5, which improved to 12.5. Now the 2 gram drop. Platelet count remained normal, but ESR CRP now sky high. So we did a repeat colonoscopy. There is a worsening picture. There is active fissure, fresh attack, multiple. Remember, I said that the whole colon was normal except the ileocecal valve. Now we started getting ulcer, in the transverse colon, ascending colon, descending colon also. So this is the picture showing 1 year after antitubercular therapy, this ulceration in the ileocecal region become more active, and there was ulcer in the other part of the colon also. So we stopped antitubercular therapy, put the level of Crohn's disease, started her on steroid induction followed by other therapy. In 3 months after the starting of treatment, initially with steroid and followed by maintenance with azathioprine, she definitely showed the improvement. Her sticks of blood decreased. She gained 5 kilo weight, 2 centimeter height in 3 months' time. Her hemoglobin improved, and ESS therapy started improving. Then expected turn of events which we face in this part of the world, majority of the patient, they will not follow up. So the loss to follow up. So what then we found out the switch over to homeopathy. This is another type of therapy this subcontinent people have a huge faith on. So they are not ready to accept the reality that this is a Crohn's require lifelong immune modulator. Say switch over to homeopathy. As expected, there is a relapse of symptom. Then she went to another center, started on Crohn's disease treatment, and she improved. So what is the final diagnosis? Crohn's disease. Now let's go to the other aspect. The second child is a 15 years old girl, came recently with history of 3 months, history of pain abdomen. She had significant anorexia, lost 5 kilo in 3 months time. She was having fever for the last 1 month. No, though she was having pain, but there is no definite features of intestinal obstruction. Like there is no history of bilious vomiting or abdominal distension associated with pain. There is no other bowel symptom, diarrhea or constipation. She didn't have any chest symptom and no history of contact with tuberculosis. This child on examination, previous child had bang normal anthropometric. Here she has wasting. Her weight was 29 kilo, which is less than third centile. Height was preserved. She had a low BMI. She was having anemia. However, there is no other deficiency signs and symptoms. No significant peripheral lymphadenopathy. Abdominal examination was normal. This child didn't have any fissure or any tag in parectal examination. Chest was normal. So same set of likely diagnosis. She was having 3 months history of pain, significant anorexia, significant weight loss, 5 kilo, and fever for 1 month. We thought tuberculosis or Crohn's. These two are the more likely diagnosis. Now she was investigated elsewhere before coming to our hospital. Somebody did the hemogram, CBC showed anemia, so they thought that this could be a celiac disease. Then they did the TTG, it was just marginally positive 24 with the upper limit of normal being 16. IgA was normal. They did duodenal biopsy, which showed chronic duodenitis with mild to moderate villus atrophy and giardia. Now, any of you will suspect celiac disease in this patient? Probably is not. 3 months history of pain, weight loss, anorexia, no way you can think about celiac disease. Now this is the problem if you do investigation which is not required, it is out of your purview. If somebody did the TTG which was positive, then they thought this is anemia, TTG positive, and by duodenal biopsy with giardia you can get some villus atrophy. So they thought this is a celiac disease and started on gluten-free diet for the next 2 months. But as expected, there is no response. This child came to us. We investigated. There was anemia and very high inflammatory markers. Platelet was 5,95,000. CRP positive ESR elevated. She had total protein albumin low. That means there is exudation of the protein in the intestine. A tuberculosis workup was normal, negative. Immune deficiency workup negative, including tissue transglutaminase, which was shown to be marginally positive outside. In our lab, it was normal with normal IgA. But next, like previous patient, we thought of TB and Crohn's, so we went ahead with top and tail endoscopy and CT enterography. This is the colonoscopic picture, almost same like the first child. Here the localized disease in the left side of the colon normal, transverse colon normal, ascending colon normal. Once we enter the cecum, there's a big ulcer in the cecum, ulcer over the ileocecal valve, and she was having linear ulcer in the terminal ileum as well. We did CT enterography. It's a long segment, more than 3 centimeters circumferential bowel wall thickening involving the terminal ileum. ileocecal junction and cecum. Besides that, there are multiple short segment thickening seen in the ileum and jejunum. There are enlarged lymph node. However, this lymph node didn't show any features of central necrosis or upper GI endoscopy was normal. This is the CT scan picture. The first film showing that long segment mural thickening of the ileocecal area, and the second and third picture showed multiple short segment narrowing in the jejunum and the ileum. Histopathology, almost similar picture, but here the colonic biopsy showed crypt distortion, cryptitis with occasional ill-formed epithelial cell granuloma. Gene Nelson stain for tuberculosis was negative. Gene expert in the biopsy was negative. Upper GI endoscopic biopsy was normal. There is no features of villus atrophy which was reported from outside. So the no celiac disease. So what is the diagnosis now? Almost similar picture. This child had pain, weight loss, fever. There is a localized disease to ileocecal region. However, her CT scan showed that long segment thickening, multiple short segment narrowing in the jejunum ileum. There was a crypt distortion. So the possibility of Crohn's was also in our mind. However, sitting in India, in an endemic country, when you don't have telltale evidence of either, we need to think about tuberculosis first. So again, this child we started on anti-tubercular therapy, though we didn't have any microbiological confirmation, and debate about Crohn's and tuberculosis was not absolutely clearly favoring Crohn's. After 2 months of anti-tubercular therapy, this child showed significant improvement. There's no pain, no fever. She gained 6 kilo weight in 2 months' time. Hemoglobin improved from 7.4 to 12.5. Her ESR dropped from 40 to 11. Albumin, which was 2, now it is 4.4. Everything suggesting that whatever lesions she had in the intestine are healing. At the end of 6 months, further improvement. She now became 46 kilo from 29. She gained 17 kilo in 6 months. She gained 7 centimeter height. Her blood parameters are absolutely bang normal. We did repeat colonoscopy at the end 6 months. See, there is mucosal healing. No ulcer anywhere in the cecum or IC valve. There is a fibrotic narrowing and gaping ileocecal valve showing there is a mucosal healing. The final diagnosis, intestinal tuberculosis. Now, what have we learned? The first case, there is a localized disease in the ileocecal area. No other segment are involved. No disease in the left colon or the right colon, any other part other than ileocecal area. CT scan was pristine. There is no small wall thickening at all. Biopsy, other than some ill-formed granuloma, there is normal crypt, thought of intestinal tuberculosis, turned out to be Crohn's disease. Second case, localized disease in the ileocecal area, deep linear ulcer in the ileum, CT scan, significant finding. The long segment, when you have a more than 3 centimeter long segment mural thickening, when there are multiple more than 3 stricture, there is more chance of Crohn's than tuberculosis. This child had the features suggestive of Crohn's. Colonic biopsy, there is a crypt distortion suggesting the chronicity, and inflammatory markers were very significantly high. We thought it is Crohn's, but turned out to be tuberculosis. So, how to sort out this confusion between Crohn's and tuberculosis? This is the chart showing what is the difference in presentation and your endoscopy and histological feature. Usually Crohn's disease patient, intestinal obstructive symptoms are very rare. None of these patients had features of obstruction. If you get a child who is having frank intestinal obstruction, is more likely to be tuberculosis. If there is a perianal disease, it is a Crohn's. First child did have deep ulcer in the anal canal fissure, so that suggests maybe Crohn's. Ulcers and stricture distribution. If you see the ulcer on colonoscopy, the ulcer is really deep, linear, serpiginous ulcer in Crohn's. In tuberculosis, it is transverse or circumferential ulcer. When you get the stricture on imaging, usually in Crohn's, they are long and multiple, more than 3 centimeters. In tuberculosis, there are fewer stricture, less than 3, and the short leg stricture. On histopathology, you can get granuloma in both, but the size of the granuloma is small in Crohn's. You get a microgranuloma. You have the large, multiple confluent granuloma in tuberculosis. Caseation is a unique feature of tuberculosis, and obviously if you get the acid first bacillus or your gene expert positivity, that is tuberculosis. Now, this is the study done in our department in SGPGI, published in 2018. Comparison between 23 children of Crohn's disease with intestinal tuberculosis. If you get a child with diarrhea, more chance of Crohn's. Blood in the stool, more often you get in Crohn's disease than tuberculosis. On the contrary, if you get a child with frank features of intestinal obstruction, that suggests tuberculosis. And if there is the extraintestinal manifestation, this is more of chance of a Crohn's disease. Now on endoscopy, if you get a left-sided colon involvement, if there is a rectum, sigmoid or descending colon, then it is more likely to be Crohn's than tuberculosis. Localized disease in the ileocecal area and IC valve, which both of our patients had, suggests more often seen in tuberculosis than Crohn's. Linear ulcer, deep ulcers are in Crohn's disease. Rest are, there is no the significant differences. Now, what we have? The first child, there is a blood in the stool. However, it is not a bloody diarrhea. She had a fissure and that was causing bleeding. So you cannot take it as a bloody diarrhea. And pain abdomen, it was there, which does not help you to differentiate whether it is a Crohn's and tuberculosis. Weight loss you get in both TB and Crohn's. Fever, if it is there, more chance of a tuberculosis, but this child did not have. What she had, perianal disease, such as Crohn's. However, this child had ileocecal valve and isolated ileocecal disease, which is features more often seen in tuberculosis. She had linear ulcer of Crohn's, granuloma, which is scattered, suggestive of Crohn's, but she didn't have any features to suggest left colonic involvement, and CT scan was normal. So what we have, she had 3 out of 5 features of Crohn's, ultimately turns out to be Crohn's. However, the second case is more interesting. She had more features suggestive of Crohn's disease. See what she had the CT scan, which is showing the long segment multiple stricture. What she had is granuloma, which is scattered granuloma. She had deep linear ulcer, suggestive of Crohn's disease. So she had 3 out of 4 features suggestive of Crohn's disease. However, it turned out to be tuberculosis. So what do we stand? The confusion remains. Now, when can we definitely say this is tuberculosis? We need to have a microbiological confirmation. However, how often we get microbiological confirmation? In the form of either gel stain positivity showing acid fast bacilli, or your culture showing acid fast bacilli, or your PCR or gene expert is positive for acid fast bacilli. Everything together for intestinal tuberculosis in 50% cases, you get microbiological confirmation, rest 50% you will not get if there is no microbiological confirmation. So what will you do when there is no microbiological confirmation? And as I showed in this consecutive chart, the clinical presentation, endoscopic feature, CT scan, there is a lot of overlap between tuberculosis and Crohn's disease. So Asia Pacific consensus statement on Crohn's disease of both 2016 and 2021 has recommended that patient with diagnostic uncertainty, I'm not talking about all patients, when there is no clear-cut diagnosis about TB or Crohn's, then they recommended 8 to 12 weeks trial of anti-tubercular treatment to prevent the dissemination. Now, what is the hindsight of it? If you give anti-tubercular treatment and delay the diagnosis of Crohn's disease, then there is an increased risk of developing complication in the form of stenosis and surgery. We have the recently published 2 studies, though adult studies, one from Asian Institute of Gastroenterology of 720 patients, and another is from All India Institute of Medical College, Delhi, of 2020 study of 760 patients of Crohn's disease. Both are retrospective study, and comparing, they have compared 1/3 of the patients receive anti-tubercular therapy for 6 months or more. When they have compared, they showed that those patients who were diagnosis was delayed because of exposure to ATT, their chance of developing stricture is much more. From inflammatory, they become more stenotic, and more often they need surgery. So we cannot blindly put the patient on ATT. We have to be more proactive in making diagnosis of Crohn's or TB. When you are stuck, then we don't have any option but to give empirical trial. So the solution when you are stuck, whether it's TB or Crohn's, since we don't have a very good biomarker to differentiate between these two, then we need to give a trial of anti-tubercular therapy for 2 to 3 months. Now this is the study from All India Institute of Medical Sciences, though adult study, but very emphatically shown the role of ATT trial. In this study, they have two cohorts. One is retrospective cohort, derivative cohort of 287 patients, 131 of them Crohn's disease and 157 intestinal tuberculosis. And they have validated cohort of 55 patients, half of them Crohn's, half of them tuberculosis. They have given anti-tubercular trial for 6 to 12 months and they repeated colonoscopy at the end of treatment. What they have shown, even those patients who are finally diagnosed to have Crohn's disease, almost 38% of them showed global symptomatic response. What does it mean? If you give anti-tubercular therapy to a Crohn's disease patient and you just rely on symptomatic improvement, you may get symptomatic improvement in almost 40% of the patient. On the contrary, the response to anti-tubercular therapy was almost universal in intestinal tuberculosis. When they have reported colonoscopy, there you can't discriminate. All patients with intestinal tuberculosis at the end of ATT, they showed mucosal healing. All the ulcers have gone. But just 5% of Crohn's disease showed any sorts of improvement on endoscopy. This 95% did not. So they come out with this algorithm. When there is a diagnostic dilemma, put the patient on empirical ATT, but keep the patient on a close follow-up, monthly follow-up. You need to check the clinical response at 2 to 3 months. If there is a no improvement or worsening, do a repeat colonoscopy. To show that there is no improvement, it's likely to be a Crohn's disease. Even if there is a significant improvement, like I showed that in Crohn's disease, 38% cases there is a clinical improvement. At the end of therapy, you need to repeat a colonoscopy to document mucosal healing to say for sure that this is tuberculosis or it is a Crohn's disease. We did a study in our department of 43 children. This is a pediatric study to document what is the effect of empirical ATT. And we have evaluated the patient monthly and then we repeated the colonoscopy at the end of 6 months. Again, the similar finding, 50% of patients who were diagnosed to have Crohn's, they showed clinical response with anti-tubercular therapy compared to 100% in intestinal tuberculosis. However, when did the repeat colonoscopy, none of the children who turned out to be Crohn's disease had any sorts of mucosal healing. On the contrary to all the intestinal tuberculosis showed in mucosal healing. So when you decide to start anti-tubercular therapy empirically, look for endoscopic healing, not the clinical response. As a pediatrician, we try to monitor the patient clinically to see how much is the weight gain, whether fever has subsided or not, whether pain has reduced or not, but you will not be able to make a difference by looking at those parameters. You need to repeat a colonoscopy to differentiate them. So to conclude, in developing countries, I guess, even in United Arab Emirates also, but tuberculosis is endemic. It is important to differentiate tuberculosis from Crohn's disease. Since we don't have a sensitive biomarker, many a times there is a difficulty we face to differentiate tuberculosis from Crohn's. And when diagnosis is uncertain, empirical anti-tubercular therapy is indicated. However, remember you need to monitor closely and you need to repeat colonoscopy. I will hammer this point. Don't rely on just clinical features or lab parameters to show improvement. You need to do a repeat colonoscopy to differentiate between these two. And after 2 to 3 months or 6 months of ATT, depending on the clinical situation, to document mucosal healing to say that this is tuberculosis or Crohn's. Thanks for your patient hearing.
Thank you very much, Professor Badar, for excellent presentation and discussion of these two interesting cases. Really, all of us we enjoyed. Now it gives me a great pleasure to invite Professor Anil Dhawan from King's College Hospital, London. He's the director of gastroenterology, hepatology, and MOVAD labs over to you, Professor Dhawan, please.
Can you see my slides or no?
Not yet.
Not yet. Share screen. No?
Not yet.
Okay, let me change the computer then. I tried another one, just 1 second.
In the meantime, once again, I would like to inform our viewers that our 8th annual Dubai Pediatric Club Conference will be held on 26-27 November in a unique hotel, the only floating hotel, Queen Elizabeth II Hotel in Dubai. The gala program dinner also will be there. We will have a 2-day conference, first day physical, second day virtual. It is free registration for all. Details will be announced. Yes, Dr. Dhawan. Once we got your screen. So all viewers are requested to join us in our annual conference. We will have lot of program, academic and non-academic. We will have a gala dinner and program with a lot of prizes. Of course, we will have the best speaker from all over the world, from United States, UK, India, and UAE.
Doctor,
The
in the
detail of that we
meantime,
will announce.
maybe we can ask Dr. Ujjwal a couple of questions that have come up in
Yes.
relation to the cases. One of the questions being asked is, was fecal calprotectin done? If not, or if done, do we really give any importance to it to differentiate between these two major diagnoses?
Very good question, Kalpana. I have not highlighted that. See, in the general pediatric practice or otherwise also, people started believing the fecal calprotectin. What is fecal calprotectin? It is basically a non-invasive biomarker. It suggests inflammation.
Yeah.
Irrespective of the etiology, whether it is a tuberculosis, whether it is a Crohn's disease, whether it is a ulcerative colitis, whether it is any infective colitis, also fecal calprotectin will be positive. So fecal calprotectin is not used to diagnose any intestinal disease. It is used for monitoring of the activity of the disease. Once you start treatment, instead of repeatedly doing colonoscopy, first you check this non-invasive marker. Suppose you are treating a patient of ulcerative colitis, so patient has showed clinical response. Now you do the fecal calprotectin, it is showing less than 100. Then this is the time you can go for colonoscopy to document mucosal healing. If the fecal calprotectin is still elevated, chances that your ulcerative colitis has not healed yet, so no point of doing colonoscopy. But fecal calprotectin cannot be used to make a diagnosis. Positive fecal calprotectin only says intestinal inflammation. So it is used to differentiate when you are thinking, is it irritable bowel syndrome, which is non-inflammatory condition, versus Crohn's disease. A patient has come with pain abdomen with some kind of weight loss. You want to differentiate, is it because of Crohn's or this is because of IBS, irritable bowel syndrome. Then you do the fecal calprotectin, which is negative, means this is not Crohn's. You are happy to make a diagnosis of functional pain abdomen.
Thank you,
Is it
Doctor.
clear?
I think Dr. Dhawan is ready with his slides.
Yes, Dr.
Continue.
Dhawan is visible now. Yeah, please, Dr. Dhawan.
My slides.
Yes, visible.
Oh, perfect. Thank you so much. I'm so sorry. I don't know really what happened, but here we
It's
are.
okay.
Thank you so much, everybody. Saurabh and others. Saurabh, thank you very much for keeping it so passionate, what you do all the time. So, ladies and gentlemen, over the next 25 minutes, I'm going to discuss some controversies. You know, we all used to this diagnosis of NASH, NAFLD, then MAFLD has come up in adults, and we believe, at least in our hospital, these both definitions are not correct for children, and it should be called PAFLD, and pediatric fatty liver disease. And we will see why it should be, and I will also discuss the diagnosis, the pathogenesis, etc. of this condition. So this is a cartoon, but children generally don't drink. And you can see, you know, children to make a diagnosis of non-alcoholic fatty liver disease is not negative diagnosis. But other than a joke, we don't ask a history of alcohol in children. So how did it all start? So it was in 1980, then in Midwest North America, in Mayo Clinic, there are a lot of patients they were seeing who had fatty livers, and liver biopsy showed features of alcoholic hepatitis, but the patients denied intake of alcohol. So then they said, well, there is something new. They don't drink alcohol, but there is a pathology liver biopsy that shows non-alcoholic fatty liver disease. So then they described this terminology as non-alcoholic fatty liver disease, or they called it NASH, non-alcoholic steatohepatitis. So but in children, we all know that all that is fat is not non-alcoholic fatty liver disease, because in children, there are other causes of fatty liver disease also. In adults, they are not. Adults' diseases, other than Wilson in an adult also, but mostly by and large, adult liver disease are viral hepatitis, alcohol, and some other rare autoimmune conditions. But in children, we see a lot of conditions, genetic disorders that has fat as a part of their illness. So in the last 5 years or 3 years, I would say more, since the COVID period, adults have also started questioning the definition of NAFLD. They also believe it's a negative diagnosis, and it is not just excluding alcohol, and every fatty liver disease is so-called non-alcoholic fatty liver disease or NASH. So what they described is that they coined the term non-metabolic syndrome. And metabolic syndrome, as we know, it's usually associated with overweight, obesity, hyperlipidemia, hypertension, impaired glucose tolerance. So what they have come up with the definition now is, they say if you have hepatic steatosis in adults, either by imaging, blood markers, or liver histology, if the patient is overweight or obese, they call it as MAFLD, and or they have lean or normal weight, and in the condition of one or two other metabolic risk factors like hypertension, hypertriglyceridemia, they call it as MAFLD, or they have type 2 diabetes mellitus, they call it as so-called metabolic associated fatty liver disease. But the problem in children is that even with this definition, it doesn't cover all of our patients. In children, we know that fatty livers are seen regularly in children who present to us with a metabolic liver disease, or so-called inherited genetic metabolic disorders. And we all know that this is related to mitochondrial stress, one way or the other, which I will come to a bit later, and that confuses the picture. We and others also started reporting that abnormal liver enzymes in a fat or a lean child should be a cautionary tale. The reason for that is that once in 2 years, we get diagnosed a child with the Wilson disease who has been treated in the community as non-alcoholic fatty liver disease, because nothing stops a fatty obese child to have Wilson disease. So that is a problem. So there are other genetic conditions because the obesity is so high in the community nowadays. So genetic disorders could be masked by false reassurance that you are just obese. So we looked at our data and we published in Journal of Hepatology that pediatric fatty liver disease all is not NAFLD. So we put this hypothesis together, and we suggested a classification based on some evidence that it should be divided into three types: pediatric fatty liver disease type 1, type 2, and type 3. Type 1 we are calling inherited metabolic disorders, which are monogenic origin: Wilson disease, tyrosinemia, fructosemia, cholesterol ester storage disease. Type 2 we are calling so-called MAFLD, that adults are calling, and type 3 is extremely important because, as you will know, in your community there are a lot of children who you believe have metabolic disorder, but you haven't got the diagnosis even after you have done the genetic test. So there is always something to be discovered. So that is a group which should be always kept in follow-up. Hence, we are calling it type 3 and not letting them go. So this is the data we did in 10 years, patients who had fatty liver disease biopsies. And we found out of these 300, over 500 patients, about 38 will fall into this category of so-called type 3, but half of them fell into the category of monogenic disorders. So biopsy-proven MAFLD was seen in in 80 patients, because biopsy we only do as part of research academic program. So in pediatrics, if you want to call it MAFLD or NAFLD or NASH, whatever you want to call it, there are simple clues. There are some clues that may make this diagnosis. What you have to pay attention is to the central obesity. They may look thin, they may not look very obese, but if their abdomen is distended, that is pointed towards NAFLD or so-called metabolic fatty liver disease. If they have elevated BMI, insulin resistance like acanthosis nigricans, male gender, not black race, Asians are also quite common after Caucasians, and if there's a family history of NAFLD or type 2 diabetes. So within this is about 15-20 years back now, when we first published our paper in 45 biopsy proven patients, and all of their workup was completed. What you see here is that most of these patients has non-specific symptoms. But if you were to took all the criteria, not about 40% of patients didn't fill into this criteria, because insulin resistance, hypertension was 65%, abnormal GTT was only 70%, but 9% had splenomegaly, which is unlike adults. In children, we see more splenomegaly at presentation, and their disease on biopsy tend to be a bit more severe compared to adults. So if you look at definition now, so it's a steatosis with or without inflammation in the absence of inherited metabolic disorder or toxin, but associated in majority with insulin and obesity and insulin resistance. Hence, we need to look into proving insulin resistance in these patients. The epidemic of obesity is central, so we can't deny that. Obesity is central to this disease. Most of our patients have it, and 10% they don't have it. What we have seen in UK, as there is a sequential data available, that from 1974, that's about 50 years, the incidence of obesity overweight is about 4 times. And now the latest data is about 37%. I think our epidemic of obesity has plateaued now. If you look at that part of the world, incidence of so-called NAFLD or non-alcoholic fatty liver disease in some African and Middle East countries is varying. So South Africa reported the highest, Egypt about 15.8%, Kuwait 33%. I didn't come across much data in UAE, but there is I'm sure Saudi Arabia has a data, but these could be biased studies, because if the center is only reporting the patients from what they're presenting to them, it's going to be higher evidence incidence. But if you're the community data, that is not there at this point in time. So the community data is not there because we haven't really agreed a definition in terms of, diagnostic criteria for this. Because some people call NAFLD or MAFLD or PFLD based on radiological diagnosis, means just ultrasound. Some community epidemiological studies will do biochemical studies only, and very small number, which are academic center, will include liver biopsy as a standard of care. By and large, the incidence appears to be over 15%. If you look at all these studies that have been performed over years, this is what is seen as normal population, so-called, and this is where 10% in excess. Most of the studies are reported here, but some are a bit under 10% also. So by and large, the community or estimate prevalence of NAFLD in the communities are going to be about 10-15%, but it depends on how much community is overall obesity is, because that will reflect it. Now, this is a very important study. This was a study done by Jeffrey Schumer's group from San Diego. And this is a study based on, this is a real true study, because it was data obtained from children who unfortunately died in road traffic accidents. So this is a road traffic accident data which showed the liver biopsy in these patients, evidence of NASH or NAFLD or fatty liver. And from this data, it comes that most of their patients were 10 years plus, very rarely below 2 to 4, which I will question the diagnosis, more boys, and most of the time they were Hispanic Americans. So it's a Hispanic Americans, boys, and more than 10 years of age. Now let's look at what causes fatty liver. How is fat and insulin resistance related to causing steatosis, steatohepatitis, and cirrhosis of the liver? So whenever we get a hepatocyte, there is an oxidative stress, and we see why this oxidative stress comes. It leads to either apoptosis and Kupffer cell activation. Kupffer cell activation, which is the resident macrophages in the liver, leads to inflammation, and apoptosis will cause cell death and will cause hepatic stellate cell activation that causes fibrosis. So we need to bring in hepatocytes under stress. So let's see how we can bring them in. So one way to get fat is, this is an example I give, how quickly the fat can go into the liver. So this is an unfortunate duck who has been force fed by this funnel, and you can make the liver grow within a few weeks. So liver can become 5 or 6 times the size, depending how much fat you are feeding this gut. And that is unfortunately done in the food industry. And this is a human example when you're eating a McDonald's burger. So you can take that way also. Now, excess fat, excess calories make us obese, but there are 2 types of obesity that we generally recognize. One is apple-shaped, other is pear-shaped. Apple-shaped is the obesity around the stomach, around the abdominal area, while pear-shaped is below the abdominal area. The reason for this is that if you have a visceral obesity, means your abdominal fat is increased, your portal circulation is draining that all fat and fatty acid that goes straight into the portal circulation. Hence, the incidence of NASH or NAFLD or MAFLD is much higher in people with central obesity versus the ones who have below the waist obesity. Now, what happens when you have excess of fatty acids in your body, whether that's excessive consumption of fatty acids or insulin resistance? So what happens is fatty acids are going into the liver cells. They are normally esterified. They are converted into triglyceride and exported as very low density lipoproteins. They also go oxidation, mitochondrial, peroxisomal, and microsomal. And in the liver cells, there is a synthesis of fatty acid also. So this is what's happening to the fatty acid metabolism in the liver cell. If there is excess of fatty acids, then these 2 pathways are going to be overloaded. And what we know from literature is that once you put this, when there's insulin resistance, there's increased uptake of fatty acid. Insulin resistance means there is increased insulin required to achieve the same amount of function that insulin normally does. So this insulin resistance causes increased uptake of fatty acids. Fatty acids will go into the liver and they will cause lipid peroxidation. And that's what I was saying earlier, that we need to stress the liver cells, called oxidative stress. The mitochondrial beta oxidation gets overloaded because there are too many fatty acids fed into the mitochondrial chain. And ultimately outcome is that there is a lipid peroxidation breakdown, and what you get is reactive oxygen species. So here we are getting at fatty acid, acyl coenzyme activation, and PPAR alpha activation. This is important step because a lot of drugs are coming to downregulate PPAR alpha. So these leads to peroxisomal oxidation and ultimately mitochondrial beta oxidation. And during this time, the mitochondrial chain gets overloaded and you get the features of increased beta oxidation and lipid peroxidation. And what it does is, all these reactive oxygen species do is you cause mitochondrial permeabilization and you cause cell death. There is a Mallory bodies, there is inflammation in the cells, and there is a stellate cell activation leads to fibrosis. So this is the pathogenesis of steatosis, steatohepatitis, and fibrosis, started with increased presence of fatty acids in the liver cells that leading to reactive oxygen species generation. Now, when you see this patient, they don't have any symptoms specifically. What they have is non-specific symptoms, or they go to your emergency department, or they come to you with a vague pain abdomen, and you do liver tests also by chance. And what happens is they get abnormal liver enzymes back. And then you give them a new disease. They came with something trivial, but you call them a fatty liver disease. The akinthosis nigricans, what you see in the back of these boys, and increased abdominal circumference. I think most of us now don't carry tapes in our rooms, measuring tapes, but if you have one, please measure the abdominal girth of this patient and you will find the diagnosis becomes little bit easier. The gold standard for academic purposes, for research purposes, is still a liver biopsy. And what you see in the liver biopsy is the variability of these holes, which is a fat which is deposited in the liver cells, and degree of fibrosis that's come like golden tissue. So liver biopsy for us and others, the academic institution stays the standard of care. Now, I have been blaming the diet a lot. Is it all excess fatty acids? Not really, because children consume a lot of fructose, and there are theories that increased fructose, increase the saturated fatty acids, and total energy intake. They're all responsible. It's not one thing that causes it. And this diagram gives you an idea of, we published this review in some time back, and it sets the stage. If you're a male sex, your ethnicity, which is Hispanics, family history, and you tend to have a polymorphism for one of these SNPs, which is PNPLA3 is most widely investigated. Early infant feeding, intrauterine development, which is extremely important. The mothers who are obese or develop in diabetes or type 2 diabetes or insulin requirement during pregnancy, their babies are at high risk of developing NAFLD in the long term. If they get into lifestyle changes, lifestyle like that causes conservation of energy and fat, increase in fat. Excess intake of fats is definitely is one which is a major contributor. Is the pediatric disease different? We get asked this question many times. There is a difference which we exactly quite not know. We published in 2009 that in pediatrics, there is in adults, the biopsy is described as type 1 and type 2. So portal inflammation, portal fibrosis in children is much more common than in adults. So 77% of children have type 2 versus 29% type 1, while in adults is different. 20 adults have majority have type 1, while minority have type 2. So these are the biopsy features. So if you look at, this is inflammation, this is a children. So NAF type 2 is more common in children, which is a fatty, which causes more fibrosis. Hence, we believe the in children, the disease may be a bit more aggressive. There are other differences also. Children eat lot of fructose. As you know, we feed them lot of fruits, and we think they're very good. So there is a change in there may be antenatal priming to these children when they were born. So there are some differences than adults. So how do we, once we have diagnosed with it, we do a liver biopsy, but in the academic setting. But if you have abnormal liver enzymes, you've excluded other conditions, and a fatty liver is showing, very likely in the setting of insulin resistance and overweight, you got the right diagnosis. So we do a annual screening on these patients with ultrasound and fibroscan, and consider a rebiopsy if the diagnosis is suspicious or the disease is progressing. We and others do increasingly fibroscans, but as you see here, fibroscan is only helpful to differentiate between very extreme and earlier on. It doesn't help much in the middle. But if you're doing the same patient serially, then it has a value. And there are other things now, MRI imagings are coming also, that may be of value. Now, this is what I want to discuss is there is a role of diets and genes and microbes. So it is not just the diet. I think there is a more to it. And what we believe is genes have a big part to play. And now there are several studies that some of us are predisposed to it. And these are the big studies that have looked at this SNPs, and a PNPLA3 comes all the time, and which appears to be a contributor. And I think that has also come from Indian studies. I haven't seen much data from UAE, but there is data from Egypt and some Saudi Arabia, which they have identified another SNP, which is more common in that population. Now, what can we do about this condition? I think it's a big problem. And in adults, it's a much bigger problem than children. And it's a massive multi-mega billion-dollar industry. In children, in adults, there are a lot of trials. I'm not going there. In children, there are trials. This was the most talked about trial called tonic study, vitamin E, metformin, which was used. And what we found in this study was that usage of vitamin E was helpful in changing the liver biopsy findings, but it didn't change the outcome. So overall outcome didn't change, but there was some change in the liver biopsy. It still stays controversial and it's not recommended routinely at the point. We don't recommend vitamin E, or unless if somebody is vitamin E deficient, then only we do it. There's a lot of attention was given to polyunsaturated fatty acids, and they are believed to act by reducing inflammation. And people have shown that they may be of value, but there are small studies. So they also really showed reduction in BMI, LTG, but not normalization. There was in the second studies, there was no improvement in ALT, but small changes, and I don't think the community really took it on, and we at our center don't use it. Similarly, work on probiotics was done, and didn't really change much. So also we don't consider that probiotics are the treatment. Now, what do we do with these patients? One thing you have to remember is it is a family disease. It's not one child. So if you happen to see the rest of the family, they will be all in this spectrum. There may be various phases of their disease, but very likely they are in the same spectrum. So my approach is in the clinic is we do a family therapy. So everybody in the family has to be treated. If you just treat one child, you are not going to succeed. So all these drugs, insulin sensitizer, etc., metformin, in adults, there is some evidence of glycosomes, etc. But in children, the problem is how long are you going to give it? All their life? While we know that weight loss does work. While vitamin E or ursodeoxycholic acid, they're not going to take it, even if you prescribe it. So the treatment for us is 3 times. It's weight loss, and more weight loss, and use family therapy. Just don't target the child telling him that you're fat, you're obese. That's where liver is not healthy. It's not going to work. But if you target the whole family, simple practice I tell the families, don't buy sugar, full stop, big statement. If you don't buy sugar, you will reduce your carbohydrate intake dramatically. So these are, every place will have their own ways of deal with it, but this is what we do. We don't believe in any of the medication at the moment because we cannot continue it for them for their life. There are new trials are coming, new drugs are coming, and adults. There's a push for those trials to be done in children. We are quite reluctant. We would like to fail these studies unless somebody is showing a very advanced fibrosis. Then I will be keen to start the treatment or different diagnosis, because in our center, we have not, I repeat myself, seen a child with so-called NASH, NAFLD, going to liver transplantation or end-stage liver disease. Countries have taken this approach, like in Mexico, in UK also, we have taken the tax on the sugar content. And this is very strong argument. If you show the family this picture, so if you look at these various drinks, the Coca-Cola or the Coke, the brand, what we are written here, I have nothing against any of these companies. This is the slide I've taken, which shows excess amount of sugar that could be in one can, which may not be 100% correct, but this is really true that we know that one full sugar or non-zero or non-diet Coke or Pepsi or anything you take has about 7 or 10 teaspoons of sugar. So that's a huge amount of sugar. So if this kind of picture they see it, nobody will be able to eat 10 teaspoons of sugar, but we can all drink all these teas and everything in one gulp. So in conclusion, ladies and gentlemen, definition is more descriptive. I think the pediatric definition is slightly different, and we need to work with adult colleagues to get this message across. Liver biopsy continues to be the gold standard. Non-invasive markers, we all working on it, are under investigation. There is no effective medication, not sure indicated in children either. These injectable medications that are coming. So weight loss is an effective treatment if you can achieve it. It's easier said than done, but if something was easy in life, then we could all do it. I thank you all for listening.
Thank you very much, Professor Dhawan, for this wonderful presentation. Beautiful diagrams. Everybody must have enjoyed. Thank you very much. And now I would like to request Dr. Miqdadi. He wanted to present an interesting case. Over to Dr. Miqdadi. Dr. Miqdadi, Senior Consultant Pediatric Gastroenterologist and Hepatologist at SKMC Abu Dhabi, is very well known in Dubai, UAE, and GCC countries and other countries as well. Thank you very much, Dr. Miqdadi. Over to you.
Thank you very much. I'm very happy to be with you all today and trying to share my screen. No, that's not what. Can you see my slides?
Not yet. No, it's okay. Yes. Go ahead.
Can you see it now?
Yes. You put the slideshow, please.
Okay, just 1 second. It's very difficult to
Yes, it's okay.
follow Dr. Duan and Dr. Jan in their fantastic presentation, but I will try my best to present this case. And I have titled the case an interesting case, but stay open-minded as much as possible. So in summary, this is a 14-year-old young girl who came to the clinic with jaundice. She had been jaundiced for the last 5 days here. She's not feeling very well. She feels tired, and her appetite is described to be decreased, and she has some mild abdominal pains. She feels a little bit nauseous, but there's no actual vomiting, and the girl and the parents felt she was warm. So this is not a rare case, and I'm sure all of you have seen patients with a similar picture. So what's next? Should we do some blood tests and arrange follow-up with general pediatrics, assuming this is a viral illness of some sort? Should we do some blood tests and arrange follow-up in a GI hepatology clinic? Or should we give her the old, therapy, give her some honey and see her in a week? Or should we admit her? I think that's the question that comes to anybody's mind. I think the most reasonable thing is to do some blood testing before we make an assumption. As Dr. Ajal mentioned at the beginning, similar disorders can present, different disorders can present with similar representations, and sometimes it's difficult to tease out what's happening with the patient in the first instance, and I will try to prove that point in this. In taking further history, she described her urine to be dark, whether that's related to the jaundice or that's from not drinking enough fluid of the poor appetite. Stool color, she's not sure. She have taken some paracetamol for this subjective fever. Probably she took it like 3 times. And actually she had eaten some food that she ordered from Talabat. Talabat is a delivery service that's well known here in UAE. And she noted that day that the food arrived a little bit late. And as you know, the weather in UAE is hot, and leaving the food outside is not the greatest idea. Her mother is a physician, and the mother, of course, is exposed to patients with different kind of viruses and other illness. Other than that, there is no sick contacts. However, her uncle was just recently diagnosed with COVID. Her past medical history, she developed some anemia in the past, and they were not sure if this current jaundice is of hemolytic origin, and if this jaundice is related to this anemia or this hemolysis. She had some problems at school, and she was labeled to have learning disability and ADHD, and they have tried her on several medications for ADHD. There's a type in the family history. Her brother is known to have G6PD. Her mother, the physician, she's known to have an autoimmune disease, which is thyroid disease. Her grandfather had liver cancer, and unfortunately, he passed away. Okay, I have added a little bit of spices here to keep everybody in their toes as much as possible. On physical exam, she looked a little bit pale. She looked jaundiced as well. Her growth parameters were within normal. Her vital signs are normal. She was a little bit combative. It was difficult to calm her down. Her liver is just palpable, 1 centimeter below the right costal margin, and it appeared to be a little bit tender. So, what's your differential diagnosis and what are the next steps in this patient? I think the differential diagnosis is very wide. Many disorders can present with a picture similar to that, and we'll try to go over the differential diagnosis one by one. So we got some labs on this patient. Her hemoglobin is low, 7.9. Obviously, that can be related to many disorders. There is a positive history of hemolysis, although G6PD is usually carrier state in ladies, but some girls, they might have a true disease. Her ALT and AST are in the 400 to 500 range, which is increased, significantly increased, probably 10 times the upper limit of normal. However, I want to remind myself and remind you all that not all ALT or AST comes from the liver. It can come from the hemolysis sometimes, specifically the AST, and it can be from other origins. It can be from the muscles and other. Her alkaline phosphatase is 600. Her total bilirubin is 10, and the direct fraction is 3.7. So she fits the category of conjugated hyperbilirubinemia. But we all know that in hemolysis, if you have a lot of hemolysis, you might get what's called insufficiency bile syndrome, and it might give you a direct hyperbilirubinemia later on. Her albumin is borderline low at level 3.4. Her total protein is 8.5. And as you can see here, there is a big gap between the albumin and the protein, and this is probably immunoglobulins in nature. Having a low albumin, it might indicate some chronicity to the disease. Her PT is 33. Her PTT is 42. So the PT is increased. Her INR is 2.7. And when you see such a high INR, I think I would be alerted that this is a severe liver disease and might be actually a fulminant hepatitis with such a high INR. The glucose is 5.1, which is against severe liver disease, but it can be normal even in the fulminant hepatitis. If it was low, this will add to the diagnosis of fulminant hepatitis. Her kidney function tests are within normal. We got an abdominal ultrasound in this young lady, and it showed some mild hepatomegaly, such non-specific finding. When I see an ultrasound, I don't really look for the size. I want to look for the echogenicity of the liver. If the echogenicity is increased, does it go with acute disease or does it go with a chronic disease? I think that's more important than the size of the liver per se. So looking at this, is it acute or chronic? I would say this is more likely to be chronic because the albumin is low. Is it mild or severe liver disease? With this degree of INR, I would call it severe disease, although the glucose is still normal. Being in a combative state, it might indicate encephalopathy in this young patient. So the question that I get asked by the junior doctors, why you call this a severe liver involvement or a liver failure? Is it the ALT? No, that's not necessarily true. You can have a severe liver disease with an increased ALT but not very high, and the other way around. You might have an end-stage liver disease with a normal ALT. And bilirubin, probably the same. The albumin, it indicates chronicity, not necessarily severity, but the coagulopathy definitely is one of the signs of severe liver involvement. So the differential diagnosis. I wish this meeting was face-to-face so we can discuss it in a more interactive way, but I will try to make it interactive if possible. I think, could this be drug related? Yeah, absolutely. This can be a drug-induced hepatitis. She's on several medications for her ADHD and learning disorder. Drug-induced liver disease can present with a large variety of symptoms and signs. Definitely the increased ALT and AST is one of the manifestations, as well as the cholestatic picture can be related to medications. And some patients, actually, they might have what's called the mixed type of involvement, i.e. Cholestatic as well as hepatitic. So drug-related absolutely can fit into this picture, and sometimes it can be fulminant, and sometimes actually we have few patients who went into liver transplant for that. Any medication can be a culprit in causing liver disorder. Of the ones that mentioned here, she took paracetamol. Usually you have to take a large dose or a chronic use of paracetamol to cause liver disease, and other neuro or psychiatric medications are well known to that. Some antibiotics are known to cause that, especially amoxicillin clavulanic acid. But again, the list is very long, including anti-TB medications and so on and so forth. The second differential that comes to my mind in this young lady, could this be an autoimmune hepatitis? Absolutely. This is the perfect age. She's a female patient. Autoimmune is more common in females. Usually it's a silent disease, and the chronicity happens over time. They might have an they might have a fulminant presentation like this patient, and hemolysis is known to happen in patients with autoimmune disorder, because again, this is another autoimmune feature, especially that her hemoglobin was 7.9. In autoimmune hepatitis, you can see transaminitis 4, 5, 6, 7, 800 range. You might see some jaundice with that, sometimes a cholestatic. So this patient profile can fit with autoimmune hepatitis. Especially that her mom is known to have thyroid, which is another autoimmune disease. And sometimes also we ask them about celiac disease or other autoimmune disorders like type 1 diabetes or vitiligo and other autoimmune disorders. Autoimmune disorders, autoimmune hepatitis type 1 and type 2 as the most described ones. This one probably will fit in type 1. Type 2 usually are younger patients, and the disease is typically more aggressive. The third differential that I have in mind is acute viral hepatitis. Absolutely. This can be hepatitis A. We all know that hepatitis A is still a common disease, even in UAE. Patient that might come with fulminant hepatitis, her feeling of not feeling well, the nausea, the subjective fever, definitely can fit with hepatitis A. Hepatitis A vaccine is not part of the national program in UAE yet. However, what's against hepatitis A that her albumin is low, so usually that indicates chronicity. But again, this would perfectly fit with hepatitis A picture. Could this be a chronic hepatitis, hepatitis B and C and others? Absolutely. Although it's less common in UAE, but it still can present with a slowly progressive disease, and now with an acute on top of chronic. Also, hepatitis E can happen, or actually any other viruses. We have seen patients with adeno, Coxsackie virus, CMV, EBV, and many, many other viruses. Also, it could be part of the COVID hepatitis as well, although typically in patients with COVID-related hepatitis, they have a severe COVID and respiratory and systemic manifestations to be part of that. Another differential diagnosis, could this be Wilson's disease? Absolutely. This is the age, a teenager patient. Wilson can present with a slowly progressive disease or sometimes fulminant hepatitis. Her liver profile goes with that, but typically the patients with Wilson's disease, their alkaline phosphatase is lower, but that does not rule out the disease. Wilson's disease is known to be associated with hemolytic anemia, and that can be actually the earlier manifestation of the disease. having some learning disorders or ADHD or other neuropsychiatric symptoms, it does fit with Wilson's disease, and we call it neuro-Wilson's, or the brain manifestations of the Wilson's, and sometimes the history can exactly fit with that. So I think I will stop here because of the time. But again, I'd like to keep everybody to stay open-minded when it comes to patients with abnormal liver enzymes. I have shown you a patient who can fit into these four categories of differential diagnosis. This particular patient turned out to be Wilson's disease, but again, it can completely fit with drug-related or autoimmune or acute or chronic viral illnesses in these patients. And again, this is emphasizes what Dr. Ajal said, that the patients with similar representations can have a totally different pathology. And it's very important to try to sort out the differential diagnosis, because obviously the management of these patients is very different depending on the etiology. Dr. Sohrab, with this, I will stop.
Thank you very much.
Happy to have any questions.
Thank you very much, Dr. Miqdadi, for excellent presentation of this interesting case. You left, I mean, you stopped in such a point, you raised so many questions. Thank you very much. Now I would like to request our moderators, Dr. Kalpana Sengupta, Senior Specialist Pediatrician at NMC Specialty Hospital, Head of Department, Secretary of the Club, Dr. Rafia Wara, Senior Specialist Pediatrician at Prime Medical Center, Jumeirah, Dr. Diari, our Chairman of the Academic Affairs, to join us. Now I would like to request Professor Dawan, Professor Ujjal, and Dr. Miqdadi to join us for discussion. Over to Dr. Kalpana for question. Now I would like to request Dr. Kalpana, since it is midnight in India, to direct questions to Professor Podar so that tomorrow he has to attend the OPD. Please.
Yeah, definitely, Doctor. Thanks to all the three speakers for their wonderful talks. We'll start the panel by asking Dr. Podar, very interesting cases, diagnostic dilemmas presented in the two cases that you shared with us, Doctor. One of the things that is being asked is, what is the role of CT enteropathy in this? At what do you do it for, more commonly nowadays for gastrointestinal diseases? Does it really add the value in these two? How much do you depend on it?
Yeah, see, primarily we have to look for the small intestine. To look at the small intestine, we have very limited modalities. So CT is one of the best way to have both mucosal and transmural disease and outside the intestine. Definitely CT helps to differentiate. There are some unique features which tells you that this is likely to be tuberculosis. Like if you get the lymph node is non-specific. I saw some of the people have asked the question about this mesenteric lymphadenopathy. But if they have big lymph node with central hypodensity, means there is a necrosis of the center, that suggests this is tuberculosis. So it's just a lymphadenopathy is not specific for any disease. But if you have a central necrosis picked up by the CT scan, that helps. Other thing is about this transmural disease. Definitely, when you are talking about the tuberculosis or Crohn's, these are the full thickness disease, transmural disease. So how much is the involvement, how much length is involved, and how many strictures are there, that helps to differentiate. See, in the investigation, nothing is 100%, but which is more common in which condition, that is important. That's why I was telling while presenting my second case that girl has features suggestive of Crohn's disease on CT scan. Because her stricture was long, it is more than 3 centimeters. She had multiple stricture in the other part of the small intestine. These are the features suggest Crohn's. But as I said, that no investigation is 100% foolproof. So you need to keep the other option open.
Right. And as far as tuberculosis goes, none of the normal markers, gene expert also, in both the cases, I think it was negative. So we can't really depend on it. And what is the relevance of positive family history in an endemic country like India? If you could elaborate on that.
Yeah, see, this is the difficulty we face, that we don't have a very good biomarker. If you have a biomarker which is 80-90% sensitivity, then it is very good. So all these biomarkers to diagnose tuberculosis, like the microbiological test we rely upon, whether it is your Zil-Nielsen stain positivity or your culture positivity, or using this PCR or gene expert, at the best you get the sensitivity around 50%. 50 to 60% cases, you are sure that this is microbiologically confirmed case of tuberculosis. But the rest of the cases, we rely on the circumstantial evidences, whether there is a family history, whether Mantoux test or IGRA test, whether the chest X-ray suggesting or not. So this is the biggest problem while facing a patient with intestinal tuberculosis. For pulmonary tuberculosis is not so difficulties, because often you get AFB positivity, because when there is a sputum or gastric aspirate AFB positivity, and you don't have much of differential diagnosis when thinking about pulmonary TB. But in intestinal tuberculosis, we have the opposite diagnosis of Crohn's, and treatment is altogether different. One, you get steroid, other you get ATT.
Dr. Shaista is asking about the timing to do scopy in these children. If you have a CT finding of cecal and ascending colon inflammation in a setup of diarrhea, weight loss, and elevated ESR, CRP, and fecal calprotectin. Child is clinically stable. When do you scope these children?
We do scopy in the first go. They say, unless or until there is a contraindication of colonoscopy, you should not defer the colonoscopy, because colonoscopy is the method which will directly visualize the disease segment. You get the tissue to process. The tissue biopsy is very important for whether it is a tuberculosis or Crohn's. Your histopathology will help in making you a decision whether it is a TB or Crohn's. So unless there is a contraindication, means patient is having toxic megacolon or you are suspecting perforation, then you should not do colonoscopy. Otherwise, any patient coming with any GI symptom without any contraindication, anytime you can do colonoscopy.
Actually, I would like to ask Dr. Dhawan and Dr. Mikdadi, what is their experience? Do they also see pediatric, intestinal tuberculosis a lot in their respective places of work?
My answer is very quick. I don't deal with it.
Okay.
I don't deal with the stools.
Okay.
Yeah.
Gastroenterology and hepatology are two different specialties in UK. So we only deal with liver, and gastroenterologists deal with gastrointestinal problems.
Sure, but is it being reported in UK? Is it still seen in UK?
Yes, there is a tuberculosis. Yes, absolutely. Yes. Yeah.
Okay. Dr. Mikdadi.
Yeah, well, actually it's there, but probably it's much less common here than probably in India. At the same time, we are dealing with patients from all over the world with different nationalities. So it's always there in the differential diagnosis. What might add to our help in the diagnosis is actually probably doing a quantiferon test in these patients. It might direct you either way on the diagnosis. Dr. Ujali presented the CT findings. We try to do MRI and MRE of the small intestine, MRI of the enterography of the small intestine. That also will give you some information about that. And it has the advantage of being without any radiation. Of course, it's more expensive and it's not available everywhere, but that's one of the tests that might help in these patients.
So that answers the question asked actually about which one to use, whether CT
May I
or
ask one
MRI.
question?
Yeah, sure, doctor.
Yeah, thank you very much for all the speakers, Dr. Podar. I have a question. Now, what's your incident of multi-drug resistant TB in kids? And is there any association like adults with HIV? My second question, a plain X-ray, we have a patient with a plain X-ray, multiple lymph node calcification, which can give a clue of TB also more than the Crohn's disease. What's your opinion?
I'll take the second question first. That plain X-ray showing calcified lymph node is suggesting you old healed tuberculosis. That will not a direct proof that this patient is having active tuberculosis. See, the
But
country like
reactivation
us
is there.
where the exposure to,
Reactivation.
there may be reactivation, yes. So if you see the whole population, 50-60% of the population is already exposed to tuberculosis. So you cannot say that exposure to tuberculosis means when the patient comes with any symptom is tuberculosis. That is one of the point we'll suggest, but you will not make a diagnosis on the basis of just a old healed calcified lymph node. About the HIV and tuberculosis, yes, HIV patients are more prone to tuberculosis. I am not aware of any pediatric data showing that this HIV and TB together.
And multi-drug resistance TB, which is now
drug-resistant tuberculosis is coming up. Yes, even from our center, we have reported out of these 34 cases of abdominal tuberculosis, 3 of them are multi-drug resistant tuberculosis, including one extended drug-resistant tuberculosis. So MDR tuberculosis is a big problem. While presenting my first case, I have not brought it. If you don't get a response to anti-tubercular therapy, it doesn't mean it's a Crohn's disease. It can be a multi-drug resistant tuberculosis also. So you have to keep your option open. Now to diagnose a multi-drug resistant tuberculosis, you need to have some microbiological confirmation. Otherwise, just empirically changing the anti-tubercular therapy from the first line to second line is not correct.
Yes. Now in pediatric age group, are you seeing colonic tuberculosis or most of them are small bowel?
Majority of them will be ileocecal. Isolated colonic involvement will be less common. Usually you get that IC.
5-6 years back, we had a case of massive intestinal bleeding, which we don't have any diagnosis. We just did laparotomy and it was ileocecal with ascending colon involvement of TB.
Yep.
Yeah.
That is the commonest site, ileocecal area.
Yes.
I just wanted to ask you, Dr. Poddar, about the diagnostic uncertainty is going to remain, especially as there is no specific biomarker, especially for Crohn's disease. And as you have highlighted in your cases. So this concept of, starting on AKT by this criteria, quite a few children would go on AKT for 2 to 3 months before you reassess and say this is TB or not TB, isn't it?
Not all patients. See, there are, I was showing those comparative table. If you have a child who is having classical picture of Crohn's means the symptom is same. You can have pain abdomen, weight loss, chronic diarrhea. But endoscopically, if you show there is a skip lesion, there is deep linear ulcers, then your histology is showing transmural disease, then you will not give ATT trial. You will investigate them. All patients of Crohn's disease, we investigate simultaneously for tuberculosis, sending them biopsy for gene expert and doing MAN2 tests, etc. Because anyway, for starting steroid, you need to rule out tuberculosis, and there is a risk of reactivation of tuberculosis after giving biologicals also. So it is a mandatory to do the tuberculosis workup. But to answer your question, it is not that all patients we should give ATT trial. ATT trial, I showed those cases only when you have a diagnostic dilemma. You have the disease which is localized to ileocecal region, what Dr. Abdul Rahman was also raising, that the location of the disease. You don't get a whole colon involvement or left colon involvement with a deep serpiginous ulcer, skip lesion, one segment involved, then no involvement. And this kind of thing, classical of Crohn's. So you don't hesitate to make a diagnosis of Crohn's. You don't hesitate to start anti-Crohn's therapy without giving ATT trial.
Right. And Crohn's, the natural course is normally a relapsing remitting kind of disease. So I was wondering when you said that they respond to AKT, I mean, they show some apparent response. Is it because they could be in that phase of remission that we think that,
Quite possible, Dr. Sengupta. Actually, the postulation why almost half of the patient of Crohn's, they show clinical response to ADT is one of the hypotheses is a waxing waning course. Another is anti-tubercular drug, they modified the intestinal microbiota because it has got antibacterial activity. That can change the picture. And the third most logical explanation is that microbacterial paratuberculosis. Microbacterial paratuberculosis has been postulated to be associated with Crohn's. So there may be some kind of change in that front. So all these three is possible, that it may be the disease course, waxing, waning, you are picking up the waning phase and telling the response, maybe the antibacterial effect of ATT, or it is a microbacterial parasitic. Previously, people used to use the anti-tubercular drug for the treatment of Crohn's. So these are the explanation given for response to ATT in Crohn's patient.
And finally, Doctor, is the incidence of Crohn increasing, do you think, in your practice?
Yes. This is all over the world. Studies showed that incidence of IBD increasing, incidence of Crohn's disease is definitely increasing. Now there are two issues here. With the Crohn's, IBD is related to both your genetics and your environment. You cannot change the genetics. It has been shown that the immigrant population were migrating from a low prevalent area to high prevalent area. So the first generation, their incidence of IBD is low. But the second generation, those kids who were born in UK or America, their Crohn's disease incidence is going up. That means the environment plays a huge role. So the changing environment, this is happening everywhere, from the developing to developed country. All these third world countries, they are improving their economic status, their hygiene is improving. So this kind of disease like allergic disease, IBD is increasing. One of the interesting hypotheses is the hygiene hypothesis. Why the Crohn's disease used to be rare to 50 years back. When kids used to play in the mud, they used to have infection, parasitic infestation. So they develop immunity or there is a immunological shift. Now all these kids are grown up in a hygienic environment. Their environment is mimicking like a developed country. So now they are developing this kind of Crohn's disease or allergic condition much more.
Would diet play any role?
There is no direct link. See, if you see the IBD pathogenesis, besides gene, environment, gut microbiota plays a role and immune system. Now the diet might change a little bit of gut microbiota, but as such, vegetarian, non-vegetarian, that, they are not directly related to the pathogenesis of IBD.
Thank you. Right. So I think we can move on to the other questions.
Megdadi, do you have anything to add? Because you deal with GI cases.
Yes, sir. Yeah, well, these cases are difficult. At least we are lucky here that we don't see much TB. So
but you do see IBD.
Yeah, we see a lot of IBD. I agree with all what you said. And one of the explanations why IBD is increasing could be related to the diet. We are eating more westernized diet, more refined diet. So that could be one of the reasons why it's increasing. And also some of the people who are managing IBD, they recommend diet therapy as one of the ways to approach these patients. And if you read the literature, they say it's as good as steroids. However, they relapse sooner than the patients who are on medical therapy.
Yeah, Dr. Rafi.
Good evening, all. Thank you very much. Very nice presentations and very important discussion. I want to ask Dr. Dahwan, actually you give us a very nice presentation about the fatty liver disease and about the obesity that we are always facing in our clinic. I want to ask you when we expect to have the fatty liver disease in teenagers if they don't have family history.
Thank you very much. So that's important. So if it's the only child, then you need to be very careful, like Wilson disease, cholesterol ester storage disease, those are the conditions. Now, it can always happen in one child also. I was generalizing it. Mostly whole family is like that. But if you have one only and others BMI are all normal, then it's odd, why that child has got different. He eats the same, he is the same family. So there you should look very hard to exclude any single gene defects in the liver.
And what is our responsibility as a pediatrician to avoid having this case, and in which age exactly we should take care of that?
So I think your responsibility is that, depending on your expertise and how experienced you have, how much investigation do you have in your hand. The case in question you said, if it's a single child, only in the family who nobody else has got insulin resistance, diabetes, everybody eats the same food, then I will have a low threshold of doing a liver biopsy in that child. Liver biopsy will add on further to investigation. It will give us the severity of liver disease. So I think your response, if you are not in a position to do liver biopsy and interpret in a multidisciplinary fashion, then I think you should hand this case over to your gastroenterology, hepatology colleagues.
Okay. You told us that there is no specific treatment. The treatment is lifestyle and weight loss. What do you think about the treatment now that it is used from the endocrinologist, actually, daily injections to control the weight and in the same time to control the glucose and the metabolic disorder?
So, that's what I said, in adults, it's possible because they are big, their lifestyle, life expectancy is not that much, and you can change it different. In children, how long we are going to give it? If you don't change their lifestyle, if the fat intake continues, sugar intake continues, you can give the medicines because medicines will not help. And it's an everyday injection, as you said, liraglutide or something they're going to give it. That's going to interfere with the growth of the child. So there are so many complications that come with it. And fortunately, I didn't show you the slide. The progression of the liver disease is very slow, fortunately. It takes up 7 to 10 years to go from one stage to the next stage. From moderate fibrosis to severe fibrosis is about 10 years. So we have to make this family aware that your child can go into cirrhosis in their 30s, in their 40s. And if they start drinking or they don't lose their weight, but it's unlikely they will come to very serious harm in the next 5 years. So yes, our job is, as you said, our responsibility is to make them aware that fatty liver disease is the most common cause of liver transplantation in adults. And if you don't change your lifestyle now, you will be one of them very likely in 10, 15, 20 years time. So that
what do you think about the diet only, diet about eating fish only? To eat only fish or only seafood to control little bit the diet?
So that's expensive way to diet. Seafood is quite expensive, at least in UK. But I think my answer to this is moderation is the answer. Everything in moderate, nothing in excess. The trouble is if they eat a lot of seafood, if they are on oysters and if they're on prawns, there is a lot of fat in it. So its total calorie also matters, how many calories you consume a day.
No, I mean, for example, you spoke about that DHA is not will not help. What do you think about salmon, something that contain more DHA, omega?
Yeah, DHA, omega also will make some difference, but if you don't lose weight, I don't think it will change.
Exactly.
That's the point. Exactly. You lose weight and DHA, omega-3, everything will help. But if you don't lose weight, I don't think it's going to help. It hasn't happened in my experience. Yes.
That is an important message that we will give to the parents and we will give to our colleagues. Thank you very much.
Exactly, Anil. Weight loss is the crux of the story. Rest
Yes.
are all superfluous. We are trying to add this drug, that drug, vitamin E, whatever it is, but at the end of the day, if the child cannot lose 10% of the body weight in next 6 months, then nothing is going to work.
I think the problem is when you start medication, they think this medication is going to fix them and they keep eating and not exercising. So that's another problem with the medication is they think they are taking a medication now, they don't need to worry about anything else.
So if they do take the proper intervention as far as weight loss is concerned, very motivated family and then equally motivated physicians, is this disease reversible?
Yes. So before cirrhosis, it's reversible. So if you are moderate fibrosis, it will get better. Mild fibrosis, definitely. Moderate, yes. Cirrhosis, depend what stage you are, if you've got portal hypertension, etc., which is we have not seen in children. But everything else is reversible.
So you showed that in your study, 49% of children showed splenomegaly. Why was that? Wasn't it because of portal hypertension?
It's not portal hypertension. It's a more inflammatory component. These children are hyper-inflamed. Their micro CRP is elevated. So this is a inflammatory component, not portal hypertension. Now, having said that, there could be a component of pre-sinusoidal portal hypertension, means the hepatic stellate cell activation. There may be some degree because nobody has done pressure studies. The real way to do would be if we did a splenic pulse pressure, which is very invasive to do it. Yeah. But we believe there could be a contribution of portal hypertension, but it's not symptomatic. Let's put it that way. They don't have varices on ultrasound or CT or MRI that we do. We rarely do endoscopy. They do get endoscopy. They continue to have GI upset. They have gastritis or feeling of abdominal pain. So they do get endoscopies, but we haven't seen varices in these children.
And I was interested to know about the publication where you said that abnormal liver enzymes in asymptomatic children, we should be concerned. So just as a guide, how abnormal? 2 times, 3 times?
I come from a liver disease, hepatology. So I will overdo everything. That's a problem little bit. So if somebody comes to me with abnormal liver test, to me, abnormal is abnormal. There is a reason they have made it in the range. Okay. 1.3, 1.5 upper limit. If there are no other things, then we don't up to two times upper limit of normal. There is no logic, but it's just to give the lab values, lab variation, etc. But for me, any abnormal test is abnormal and it needs the same respect as you will do with any number. So number to me doesn't matter. As Dr. Mikdadi said, AST, ALT in cirrhosis could be normal, while it could be 1000 and your liver biopsy may not show much. So when
what would your,
Sorry, say it again, Kalpana.
No, I was just saying, so what would your approach be in such a case? How far would you go to?
If the liver tests are persistently abnormal, if you do it once, child is well, no other concerns, repeat it in 3 months, is still abnormal, you can either pull the trigger and do all the investigations, wait another 3 months. But if it's persistently abnormal for 6 months, you definitely have to exclude all other causes.
What are some of the common causes you would find in them?
The common things will show up easily. So if there's a viral hepatitis, you will have jaundice, you will have it. Okay. If you have autoimmune, you've got autoantibody positivity, you will get the other test. In other words, liver, spleen, ultrasound will be abnormal. If you have Wilson disease, you will get ceruloplasmin, urinary copper, etc. But I mean is to trigger these tests. So it depends on the age also. If the child is young, then I will do all inherited metabolic disorders. If child is bigger, then you can pick and choose a little bit. But we will not leave them uninvestigated. The basic set of investigation we will do is an ultrasound scan. We'll do prothrombin time, autoantibodies, Wilson, and for very young infants, you exclude galactosemia, tyrosinemia. What I mean is investigate anything that is treatable. You will not be crucified if you missed a rare diagnosis that has no treatment. But we will be crucified if we miss a Wilson disease or a tyrosinemia or galactosemia. So always think of a treatable condition, exclude those, then you can take your time as much as you want.
Right. Dr. Mikdadi, what is the UAE data? You'll have some idea about that, and as far as the fatty liver in children is concerned.
Well, that's an excellent question. I'm not aware if there is any specific publication, but the finding of quote unquote fatty liver changes in the ultrasound that was done for some other region is not rare at all. And increase in liver enzymes is not rare at all. As Professor Dewan explained, it's really very difficult to diagnose these patients as you need to rule out the more common causes. And what I do in my patients with suspected fatty liver disease, after we have ruled out the more common causes, I tell them the following: you have to be on a diet and reasonable lifestyle, and to decrease your weight. And after that, we'll see the response. If your weight improves, i.e. decreases, and your liver enzymes are normalizing, then I will be more reassured that this is fatty liver disease, although that's not 100% the case. And if they don't, if the weight improves but the liver enzymes continue to be high, then we'll probably do the second or third tier of investigating these patients. As Professor Dewan mentioned clearly, there's no specific diagnostic test, but you have to rule out the other more common treatable ones.
Well, since the incidence is rising in the current scenario, is there not a move to have some criteria which would combine some radiological and histopathological criteria, Dr. Dhawan?
No, so the problem is there are criteria. So in adults, it's very easy. They exclude hepatitis B, C, autoimmune liver disease, and alcohol, and they say it's a non-alcoholic fatty liver disease. Now, if you were to do it if you do an MRI planar's imaging that showed fat. Now, the problem that we have is in children is fat could be a manifestation of underlying metabolic condition. So that does not, and child could be obese because that's a lifestyle. So our problem is to exclude an underlying treatable liver disease. So there are criteria, but then those criteria tells you more about severity, not diagnosis. In adults, it's a diagnosis of an exclusion. As I said, if they have overweight, no alcohol, they will call you non-alcoholic fatty liver disease. But in children, my word of caution is don't do it, because I have seen in my practice, children managed with Wilson disease, autoimmune liver disease as fatty liver outside. Because they were right. The child was obese, has some of the liver function test. They kept saying reduce weight and it will get better, but it didn't. But they do have other underlying chronic disease which needs a very different treatment. So numbers
we should not assume that it is fatty.
But even one misdiagnosis of autoimmune disease is too much for us.
May I interrupt or ask one question? Dr. Mirdadi left us in differential diagnosis. What was the diagnosis of his case?
Wilson.
Was it Wilson or something else?
Yeah, well, the case I mentioned, I made it a little bit more with spices to stimulate everybody. This patient ended up having Wilson's disease. But again, I would not be surprised if this patient will fit in the diagnosis of autoimmune. There's a lot of features in the case that I presented that might fit with autoimmune or drug-induced or viral hepatitis or other causes. So the message, I think, is that patients with similar presentation can have a totally different etiology. And Professor Dewan mentioned, some of the patients who might end up having Wilson and they were diagnosed to have fatty liver disease or others. So I think, careful evaluation of these patients and follow-up is a key in reaching the right diagnosis.
Dr. Mirdadi, what was the Coombs test on your child?
I don't recall.
So that will be helpful. In Wilson, usually it's Coombs negative, and autoimmune usually Coombs. As you said, it could be either. But you must have got a genetic diagnosis by now, so that may help you.
Yeah, the genetic diagnosis confirmed Wilson, but actually the hemolysis was severe that she got even a bone marrow biopsy at the time. And also, to add to her bad luck, she had a parvovirus IgM that was positive. So they thought this is a parvovirus. But anyways, I mean, the purpose of presenting this case is to keep everybody open-minded, not to miss any of the important diagnoses.
Yeah. At the moment, we are seeing a lot of hepatitis A, Dr. Miqdadi here, as people have traveled and come back, schools have reopened. A lot of
Yeah,
cases coming.
yeah. In the last couple of weeks, I have seen a few patients with hepatitis A or etc. And hepatitis C is not rare either.
Yeah,
That is-
Dr. Magdadi, you told us that the girl is 14 years old. Why no one put the diagnosis for her before that? Why she was not diagnosed? The mother is physician, and why till 14 years old? Wilson can be diagnosed before.
Absolutely correct. However, the symptoms, in early Wilson, you don't have symptoms. Most of the time, you just pick it up in liver enzymes when they are checked. And again, a word of caution. I'm sure you have seen a lot of patients with COVID, and at least I have a couple of examples where COVID was blamed for different manifestations, whether it's hepatitis or others. But keep in mind that not every patient with COVID and hepatitis is a COVID-related hepatitis. He could have COVID, but totally different disease or any other manifestation. I think COVID is being overestimated to cause many symptoms. That's not necessarily the case.
Migdadi, can I make a comment related to your patient? This
Sure.
child had abnormal behavior before in the school. She was diagnosed with ADHD. Is it possible that she had Wilson disease with neurological manifestation which was not paid attention to?
Absolutely, it could be related or just coincidental. However, typically the neuro Wilson, it happens later on life, and I will ask Dr. Dewan to comment on how frequent you see neuro Wilsons in teenagers. Is it?
So number is about 10%. Those who are presenting to us with predominantly liver presentation, like this child who presented with jaundice. But what we have found now, further investigation is psychosocial depression, anxiety, ADHD are far more common than we thought before. Now we are systematically, we have a psychologist in the Wilson Clinic. So we are already evaluating them, and increasingly we are finding that incidence of psychological issues is much higher in children below 15 than bigger. The hard neurological signs like tremors and others, we see it about 5% in the liver patients, but as they grow older, the incidence increases.
And do you treat these kind of patients differently, Professor Dewan?
Yes. So once they get diagnosed with either a neuropsychiatric or a psychological problem, then they go into antidepressants or anti-ADHD drugs. Yes.
No, I mean for Wilson's, do you give them more trientine than
No,
penicillamine?
our standard drug is penicillamine, first line drug. Because in UK, trientine is not licensed unless you are penicillamine toxic. Unless you cannot tolerate penicillamine, then only can you prescribe trientine. We can't prescribe it as a first line drug.
If this is licensed in UK, would you have the preference of trientine in patients with neuro Wilson manifestations?
If she was a patient in UK, she will get penicillamine as first line drug.
Okay.
If she gets neurologically worse, which can happen in 10-15%, then she can go to trientine.
What about zinc, doctor?
Zinc for liver disease is a problem because liver disease is quite severe, and just zinc bioavailability is poor. People have used it, people still use it, and zinc, people depend on what preparation they're using of zinc. So zinc acetate is the least toxic, but it's very expensive. Zinc sulfate is the most cheaper than others, but it's not toxic. There are a lot of GI side effects with zinc. And zinc is not a chelator. Zinc will not deplete your copper. Zinc will just reduce your absorption of copper. So the time it will take for you to get into some chelation of the copper, it will be years. So we do not treat zinc as a first line. I've tried it, in all fairness, in 3 children who were diagnosed 2 years of age. The family history, there is a child from Middle East. I have 2 children from Middle East whose the elder child had a Wilson. The family had an antenatal diagnosis. Baby was born. There was no problem, but the genetics on a baby were positive. Waited for 2 years. Before 2 years, the liver enzyme became abnormal. I started zinc, hoping that this is the best drug. Within 2 years, I have to switch her to Triantin because they wanted Triantin. So it didn't work. Even at that age, a Korean child, 2 children from Qatar, it didn't work in my experience. Other people say it works. I think Wilson is a very strange disease because you can have Wilson disease and not have any symptom all your life. There was a 76-year-old woman admitted to a hospital in New York with abdominal pain, and a gastroenterologist started investigating her, and one was a hepatologist. He ordered ceruloplasmin, and she had a diagnosis of Wilson at the age of 76, but she wasn't symptomatic with Wilson all her life. But if you did her genetics at the age of 2 years, she would have been Wilson disease.
Yeah.
So it is a strange disease. There are so many modifiers in it. Everybody behaves differently. So our experience with zinc is extremely, extremely limited, and we don't redo it as a first-line drug.
Do you use zinc acetate or zinc sulfate in your
Zinc
patient?
acetate. Zinc acetate is easily tolerated, and it's a bioavailability, it's a licensed drug. Zinc sulfate has not been tested, but people use it. It's a cheap drug, but the bioavailability is very poor. And there is a Polish data who has done endoscopy and showed quite severe gastritis and gastric ulcers on those patients.
Anil, you will agree and you will rightly emphasize, zinc does not help in treating Wilson disease. Disease means when there is a excess copper in the body, is causing damage to the liver. You want to get rid of this excess copper by chelation. Zinc does not help in chelating copper. What zinc does, it prevents the absorption of copper. Means you need to go to that state when there is no more excess copper in the body, and then you want further accumulation, and at that state zinc might help. So at the base, zinc may be used once you reach that state for maintenance therapy. I don't think zinc should be used as an induction therapy.
But is there any harm of using both of them together?
So there is a problem with that, because if you look at the, when you give zinc and when you give Triantin or penicillin, if you using one or the other and zinc, you need to have few hours difference, because those drugs are chelators. So if you give zinc, penicillin or Triantin, they will absorb it. They will not let it absorb, so waste it. What you can do is, if you really want to do it, then do a lunchtime dose of zinc if you want to do it. We have done it in severe zinc patients who had quite a high Wilson index, and we were trying to rescue them as much as we can. So we gave a morning, evening dose of penicillin and a lunchtime zinc. That is several hours difference. But if you give twice a day zinc and twice a day penicillin and Triantin, then you can't practically do it. Then the child has to wake up 5, 6 in the morning, take one medication, then take another one at 9 o'clock, then the same thing in the evening, and same thing you go back to the school. So practically it's not possible, and it makes life extremely difficult. If you're using Triantin, penicillin, they're so strong chelators, you don't need anything in addition.
Actually, Anil, these two are contradictory drugs. They don't have synergism.
No.
Zinc
What I meant is, you will be absorbing zinc. So what you will do is you will chelate zinc with the penicillin, and they're heavy metal chelators. So
not only that, probably zinc interferes the absorption of dipenicillamine at the enterocyte level. So that's why we try to give it separately. But you rightly said, you have to give dipenicillamine 2 or 3 times a day, and then you split the zinc another 3 times. So the child will no time to sleep. The whole day and whole night, he will just calculate the hours when to take zinc, when to take dipenicillamine.
Okay.
It's an interesting disease. I want to see, Professor Diwan, I have families who have like 3 to 4 patients with Wilson's disease. However, the disease manifestation is different.
Yeah.
And typically, you know, the older you are, the more severe, the older you are at the time of diagnosis is severe. But at least in one family, and they have the same mutation, the older child is doing very well, clinically, laboratory by the liver enzyme and the liver biopsy, than the one who's younger patient. Is there any logical scientific explanation?
So epigenetics and gene modifiers. So they will determine the active effect of the gene and gene product. Now you can quantitate. Now there are tests coming, they can quantitate the gene product of ATP7B. So that is a possible, but that will just give you a curiosity, but it wouldn't change the patient management. In other words, his genetic makeup is such, his epigenetics are such that he's going to have poor man has going to have a bad disease.
Moving on, slightly away from the topic, I would like Dr. Podar and Dr. Mikdadi to comment on common questions being asked regarding H. pylori in children. Diagnostic test, should we treat, should we not treat? It's the biggest dilemma. So, Dr. Mikdadi.
Well, if you allow me to go, H. pylori is a common diagnosis. And a lot of patients probably they harbor H. pylori in their stomach. However, it does not necessarily cause the symptoms that the patient have. In my practice, when I see somebody with abdominal pain and H. pylori positive, it's more likely than not that their symptoms are caused by something else like constipation or others. So having an H. pylori does not equate having symptoms.
Okay.
Dr. Kalpana, how H. pylori is diagnosed in your country? By endoscopic method or by serological method or by just stool antigen test?
These are just questions by normal pediatricians doing OPD practice, doctor. So more often than not, stool antigen and want to know when to do breath test. This is the question.
No, see the question, the answer to the first question, if the H. pylori positive, will you treat or not, depends on
Yes.
how you have diagnosed.
How
If
we
you
have
have diagnosed just on the basis of
stool antigen, most of the
serological
times.
test or stool antigen test, that will not tell you that this is a commensal H. pylori and this H. pylori has caused some disease. When there is a disease means there is a ulcer disease. There is a gastric ulcer, duodenal ulcer, or rarely malt lymphoma. These are the disease, or adenocarcinoma. These are the disease causes by H. pylori. So it is a disease which needs to be treated, but just isolating H. pylori in a child who is having pain abdomen, this is not an indication for treatment. Even our European Society guideline clearly said that there is no association of functional abdominal pain and H. pylori, and we should not look for H. pylori as a cause of pain abdomen in this patient. However, when you are doing endoscopy for some other reason and H. pylori is detected, then this option should be given to the parents that by treating H. pylori, you are not going to get rid of the pain. So this option, if they agreed, yes, I want to get rid of this bug, you treat, but otherwise you blankly just making a diagnosis of H. pylori and treating is not indicated.
I agree. I mean, before testing for H. pylori, you should be ready to accept the results and ready to treat it. But that's the dilemma. We give the test to be abnormal, but we don't feel that it's the cause of the symptoms. Also, in other indication for treat, if there is a positive family history of gastric cancer, I think that's one of the indications to treat H. pylori as well.
I think there's another question by a gastroenterologist, Dr. Rajneesh Rajan, to Dr. Anil Dhawan. Any role of insulin resistance indices like HOMA-IR or hepatic IR in predicting severity of fatty liver disease?
Not predicting severity, but towards diagnosis. So
Okay.
insulin resistance or HOMA, they are part of the discussion. So that's why insulin resistance proving is important. And insulin resistance also gets better if you lose weight. So yes, some places use insulin resistance, some uses insulin sensitivity test. They're all interchangeable terms, but different methodology how you test for it. But yes, if you have access to these things, then yes, it's helpful to do.
Sure. Dr. Nasma wants to ask, does fasting worsen the fatty liver disease? Do you recommend slow weight loss?
Well, we recommend 5% weight loss in 6 months. But rapid weight loss has its own problem, but how do you achieve it? Even people who go bariatric surgery, etc., they also achieve relatively faster, but it's still acceptable weight loss. And they can get fatty liver because of that also, rapid weight loss. But predominantly, I think our goal is 5% 6 months. If they can achieve that, that's a good way to do it. And that's also sustainable. If somebody loses weight slowly, they are going to sustain it. If they lose it fast, they put it back again.
May I ask Professor Dewan if you would like to comment on the artificial sweeteners?
Yes. So artificial sweeteners are not a good news because what they do is there is a study which is very interesting. So they looked at water, fizzy water, artificial sweeteners, and the standard fizzy drinks that we have. Other than water, even if you are having a fizzy drink without sweeteners, that upregulates your GLP pathway and you feel more hungry. So all these things increase your appetite. So when you're taking this Diet Coke or Coke Zero or Diet Pepsi, Coke Pepsi Zero or whatever they call them, they will increase your appetite. So your hormonal parameters are they're slightly better than full sugar drinks, but they are not normal still. And then there are people say other things about sweeteners that I don't know, but in the setting of a liver disease or GI, that I know that GLP upregulation is demonstrated.
So having a Diet Coke is not necessarily the answer at all.
Plain simple water is the answer if you can live with it.
Okay, we'll have some water then.
Anything artificial is generally not a good news.
Yeah, you are right that way. I think, yeah.
No, because it's, some people, lay people, they believe if you are drinking a diet soda, then you are off the hook, and that's obviously not the case.
So they are off the hook for calories. That's true. So, the picture I showed you, 35 grams of sugar in one. Yeah, that is gone. But your GLP activation, your absorption of food will increase, and your calorie, what you're eating after that will be much more efficient. So they will produce more fat from that meal they are going to have afterwards.
Exactly.
Okay.
I have one question again to Dr. Magdadi. Then the message to take home for the treatment of Helicobacter. If we have patient and he comes with epigastric pain and abdominal pain, epigastric pain, low appetite, sometimes nausea, and in the stool analysis, the antigen of the Helicobacter is positive. We treat him or we will not treat him, or we will we will suggest the endoscopy, and if the parents refuse or if the insurance refuse, what we will make?
In that setting, somebody with abdominal complaints and positive H. pylori, first of all, I would like to look for other causes of abdominal pain, because it's more common to find other causes than H. pylori. That's the commonest is probably constipation. Then you have to look for other causes like liver, pancreatic, or other disorders, and urine analysis, blah, 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 blah. If the H. pylori antigen in the stool is positive, even if the symptoms do not fade, as Professor Ajal mentioned, it's really difficult to treat or not to treat. I mean, the world is divided. Should you treat or not to treat? For me personally, I discuss it with the family, but I lean more towards treating it, although knowing that it's not going to affect the symptoms, for the simple fact that H. pylori is one of the carcinogens, and it's WHO have classified it as a carcinogen. Although the risk is very, very low, and it will take many, many years to do that. But I think if the parents read somewhere that H. pylori can induce cancer, one in whatever thousands of people, they want to get rid of it. Although, again, it will not affect the symptoms. So in short summary, I would offer the treatment, although knowing it will not affect their symptoms and probably have no bearing on that at all. However, H. pylori is one of the carcinogens when it comes to gastric cancer. But I totally understand that some other colleagues, they don't want to treat it for the same reasons.
Okay, thank you, Doctor. Doctor, you mentioned about the constipation. Can I ask you, what is the duration of the treatment, the functional constipation in the children?
As I always say, everybody is constipated until proven otherwise. I think a lot of children are constipated. The symptoms are not usually obvious, and I think constipation is super common. How long you treat it?
Yes.
I would say as long as it takes to get them back to normal habits. Typically, it's going to be several months, 4, 6 months, even longer. Obviously, the longer the constipation has been there, the longer you need to treat. The more severe, probably the longer you have to treat. So it has to be several months at the minimum. And I don't know
Is
if
it-
Dr. Yes.
Yeah, is it
Yeah.
important always to rule out the celiac disease if we have we are facing the patient coming first time to us with history of constipation, any silent celiac disease?
Celiac disease is not rare at all, especially in the Middle East. Estimates are 1% or 1 in 200 patients. So it's not rare at all. I have picked several patients who have celiac disease, and the only manifestations was constipation, without failure to thrive, without any diarrhea, without anything, just the constipation. And in the same saying, also it might cause some increase in the liver enzymes. In our center, we have picked few patients who came in with increased liver enzymes, and again, the abnormality was a celiac disease. It's one of the known manifestations, although it's not that common. So the short answer to the question, I would keep celiac in mind, and I would suggest to screen by celiac serology in patients with abdominal pains, constipation, or increased liver enzymes in the right setting.
Okay, my last
Dr.
question.
Duan, do you screen everybody with increased liver enzymes for celiac? Professor Duan?
That again? Sorry, I was.
Do you screen everybody for celiac if they have increased liver enzymes and no other obvious etiology?
No, if you are suspecting autoimmune, then we do that. But if they have other symptoms of celiac, then we do. We should do it maybe, but if we don't have any already symptoms, then we don't. The autoimmune liver disease all get celiac screening done, and the ones if they have symptom, then only, but not specifically we don't go for celiac disease.
Can I make a comment here?
Yes.
Rafia?
Yes, I have one question about
No,
what
but can I add what
please.
Megdadi said about constipation?
Yes,
See,
please.
the treatment guideline for constipation is very simple. After disinfection, you start maintenance therapy with laxative, and you need to give time for colon to come back to the normal function. So the duration of therapy you give is basically when you start treatment is a hugely distended rectum. It doesn't serve the purpose. It doesn't function properly. Now you need to give time for colon to come back to the normal tone, muscle to start functioning normally. So the usual target is you achieve the target, the 2 to 3 soft stool per day with laxative, and from then you give another 3 to 6 months. So duration depends on how soon you are achieving your target, and after that you explain that it is not that you should stop. After 2 weeks, 3 weeks stop means recurrence. You need to give 3 to 6 month time for regaining of function of the normal colon. So that is important. Dr. Magdadi, I don't know how strong is the relation between celiac disease and constipation. There's one study 20 years back showed that constipation as a manifestation of CMPA, subsequently no study. So I'm not sure about this association of constipation and celiac disease, because constipation is very common.
Very common.
As you said, that every alternate patient child probably come to your clinic having constipation. Celiac is common, but not so common. So if you have the constipation without any other features, screening all of them for celiac, I don't know whether it is logical or not.
I
had
agree
also
with you
one
whether
question.
that's the celiac causing the constipation or just coincidental. Constipation is very common. So if you check for anything, you will find it. That's a possibility. Yeah, but I mean, the classical teaching, they taught us that celiac is associated with diarrhea, failure to thrive, blah, blah, blah. Obviously, that's not the case these days. Yeah.
Dr. Rafia, may I add also?
That
Actually, we have a treatment inertia or physician not giving the proper dose. And then the shopping of the patient going from doctor to doctor. So when there is one doctor saying that don't give this amount, they give less. And once they improve, they stop the treatment. I mean, after 1 week, 2 weeks, they stop. Although they have been there for chronic constipation for years, in 2, 3 weeks, they are stopping and giving little amount. Honestly, we found that to give bigger dose is much, much better than to give little. That was our opinion also.
I have question for all of my colleagues here. What about the probiotic in the treatment of constipation?
Simple
Dr.
answer,
Ujja?
it doesn't help. It doesn't help.
Dr. Magdadi?
Yeah, I don't think it helps in this group of patients, although I see many patients who are taking it. I don't know if it's really a placebo effect or what, but there's, if you want to give it, it has to be given in addition to the laxatives. I don't think probiotics alone will treat constipation. I really, really don't think so.
One question I would like to ask here. I advise food. Some people, they don't be. What is the relation of food and constipation? What type of food to be given, what not to be given? This is a question mothers, they ask. And I always try to find out, Dr. Podak, you start please. What do you advise when the patient comes with constipation as far as food is concerned?
So, Sora, very interesting issue, the diet and constipation. What our experience suggests, I guess it's the experience of your country pediatrician also. Most of these kids who develop constipation, they are heavily relying on milk. They are drinking 2 liters of milk, and the mother neglect the other food stuff, mainly contains fiber. So the first and foremost thing what we do in our practice, we drastically reduce the milk intake. If, unless or until you reduce a 2 years old child who is taking 5 bottles of milk, where is the space for taking other food? So you need to reduce drastically the milk intake. Then only the mother will be able to give some kind of food with high fiber. So the high fiber comes after the reduction of the milk. So high fiber definitely depends depending on the age of this child. In an infant, you cannot say you start taking uh, green vegetable salad. Obviously, these are all useless. So you need to modify whatever the diet this child is on, how you can increase the fiber content. So the first step, reduce the milk, try to introduce more of a solid food. And among the solid food, you have to choose, depending upon the local cultural habit and food habit, what food you can change by increasing the fiber. Big Daddy, what is your experience about this milk story?
I totally agree with you. I call it the milk or the liquid diet. And these kids, they drink all this kind of liquid drinks that will satisfy them shortly, and they end up getting too much calories and fat, and then they would get fatty liver disease. Yeah, totally agree.
Well, Dr. Ujjal, raw banana, I have found that raw banana causes constipation. Although some people say fiber, what I found, in fact, I read also raw banana causes constipation. What is your opinion?
No, banana doesn't have much of fiber. See, regarding the fruits in a bigger child, you need to think that what is the digestible and undigestible fiber. You need to increase the undigestible fiber, and the fiber is there on the outer coating of any fruits and vegetables. So if a child is taking apple, the mother needs to give apple with that peel. There is a common practice of removing the peel. Sometimes they boil the apple and then give it to a child. That is a hopeless, useless practice. If you increase the fiber, whatever fruits their child is taking, it has to be intact with the peel. The outer coating has got the maximum fiber. Coming about the banana, yes, that what you were talking about, ripe banana and green banana. The ripe banana doesn't have much fiber. Green banana has got something which is unique. It has got amylase resistant starch. That is not a fiber. Actually, that helps in persistent diarrhea or even in the diarrhea. It goes to the colon, it gets fermented and produce short chain fatty acid, and that helps in absorption of the water. But as such, the banana is not used for constipation.
Yeah, but so Rob, come on, I hear this frequently, but how much banana can a child eat?
Yes.
I don't know. I mean, it's not going to eat much. And I think if you tell the parents, don't give them bananas, they start craving and dreaming of bananas. So Yeah, I think Professor Dewan mentioned earlier, everything in moderation. You know, if he eats one piece of banana every day or every other day, you know, there's no harm of that. But if he's living with bananas, that's a different story.
No, but what
That's why I'm
Dr.
so
Sorab
happy. Sorry,
is asking, I think, no, I just wanted to clarify, that is raw banana what you're talking about, right, Dr. Sorab?
Yes, raw banana.
That is used as a vegetable in Indian households, and that is not something the child can just eat like that.
No, even normal banana, we have ripe one, we have green. I mean, a banana which is not fully ripe. I found South India, they take a lot of banana. I found this one, I've tried it myself also. Raw banana causes constipation, and I've asked patients also.
But that is
This
what
one.
is known, doctor, that there is a difference between raw and ripe
Just
sweet
it was a
banana.
question I wanted to clarify experts.
I think Dr. Dhawan wanted to say
No,
something.
I just wanted to say how happy I feel, you know, I don't have to deal with all this. The liver, you know that. Blood test will tell us, or change the liver, life will be different.
Kalpana, it is
Good
midnight,
idea.
1 o'clock midnight in
I think we
India.
should stop long ago. I was really
No,
thinking.
one thing, I asked a question about who is in that picture. Only Dr. Kalpana has answered right. Professor Alex P. Movats. In 1970, he opened the Pediatric Hepatology in England. He wrote his book in 79. He went to Chile. Unfortunately, after a talk, he got a heart attack in 2005. He's a pioneer and father of pediatric pathology in England, and now Professor Dhawan is continuing as a director of that center. That was the answer. I would like to thank all the speakers, Professor Dhawan, Professor Poddar, Dr. Miqdadi, Dr. Kalpana, Dr. Rafia, Dr. Diari, Tawfiq for sponsoring this, all viewers who are with us till this time, midnight now, 1 o'clock midnight. Thank you very much.